Good morning, Director Cheng. Can we test your connection? Good morning, Director Cheng. Can you hear us? Sorry, I believe you're muted.
Hi, I can hear you. Can you hear me?
Thank you. Yeah, we can hear and see you clearly.
Perfect. Thank you.
Good morning, everybody. We're just waiting for quorum. Once we have quorum, we'll start.
Good morning, Councillor Cheng. Can we test your connection? Sorry, we can see you, but we can't hear you. Good morning, Director Zhao. Can we test your connection?
Sure. Are you able to hear me?
Thank you. We can hear and see you clearly.
Great.
Testing, testing, 1, 2, 3. Can you hear me?
Perfect. We can hear and see you clearly. Thank you.
Great, thank you.
So good morning, everybody. My name is Councillor Chris Moyes, and I am the Chair of the Board of Health. The Board Secretary has confirmed that we have quorum. So I'll call meeting 29 of the Board of Health to order. Today's meeting is being held by video conference and in person at City Hall in Council Chambers. Because we are meeting in person and remotely, we ask everyone for their patience with any delays and technical issues. If you are registered to speak at today's meeting, please listen for me to call your name. I will call speakers in the order they appear on the list. The list of speakers can be viewed online by visiting the Board of Health page at toronto.ca/council and clicking the speakers box for today's meeting. The Board Secretary has provided all agenda materials on toronto.ca/council and via CMP, the clerk's meeting portal. Directors, please ensure that your video is turned on. Please keep your mic muted unless you wish to question staff or speak on an item. As part of each agenda item, I will ask directors to raise their hand or unmute their mic if they wish to question staff or to speak. I will then create a speakers list and will call on directors when it is their turn to speak. When voting on an item or a motion, I ask that directors ensure that they turn on their mic and video and to raise their hand to indicate their vote. Directors, I want to remind you that you can submit and approve your motions by email. Staff are available at boh@toronto.ca to help with motions. The Board of Health acknowledges that the land we are meeting on is the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. The City of Toronto acknowledges all treaty peoples, including those who came here as settlers, as migrants, either in this generation or generations past, and those of us who came here involuntarily, particularly those brought to these lands as a result of the transatlantic slave trade and slavery. We pay tribute to those ancestors of African origin descent. Are there any declarations of interest under the Municipal Conflict of Interest Act? If you have an interest, please raise your hand or unmute your mic and indicate the item number and the nature of the interest. Seeing none. Next, we need a motion to confirm the minutes from our last Board of meeting on October 27, 2025. Director Chandrabalan, all those in favor? Opposed? Carried. We have a full house, it looks like. So good morning to everybody, here and online. We have made it to a final meeting of 2025. I'd like to begin by welcoming our new Board of Health Director, Councillor Rachel Chonslin, who represents Don Valley West. She also brings with her 6 years of experience as a trustee of the Toronto District School Board, including 2 years as chair. I'm very happy that she has decided to join us here at the Board of Health, and I look forward to learning from the perspectives she'll bring to this work. So let's give a round of applause. Don't blush too much. Before we get into the agenda, I want to touch on a few pieces of public health news that are pertinent to the work here at the city. Firstly, as you may have heard, Canada has officially lost its measles elimination status after we experienced sustained transmission of the same measles virus strain for over a year. This is extremely disappointing news, as we had eliminated measles in Canada since 1998. But all is not lost. We will have the opportunity to regain our status. Vaccine update is key for mitigating measles outbreaks. Fortunately, our team at Toronto Public Health have been hard at work to get residents back on track with routine vaccinations, especially among students. Just a few months ago, we received a presentation about Toronto Public Health's response to the measles outbreak in Ontario. At that time, we identified gaps in the system and requested the Ministry of Health to address them. These recommendations included the development of a comprehensive provincial strategy to increase vaccine confidence and vaccination rates for measles, as well as the consolidation of electronic vaccine medical records with public health records. With very few confirmed cases of measles this year, the city is doing our part to prevent the spread, but our efforts are just one factor. I do hope that the ministry sees our loss of elimination status as a wake-up call to enact some of the changes we've requested. Also troubling to hear about was the plateau in cervical cancer that rates we're experiencing after several years of steady decline. Unlike many common cancers, cervical cancer is highly preventable through vaccination and screening for HPV, human papillomavirus, which typically causes cervical cancer. This means that, in theory, if vaccination and routine screenings are adopted widely, we could virtually eliminate this type of cancer. So to see our progress halted is upsetting. Currently, only students in grades 7 through 12 and men up to the age of 26 who identify as gay, bisexual, or trans, or as having sex with men can access the HPV vaccine for free. But we know that without immunization, 3 out of 4 sexually active Canadians will be infected with HPV at some point in their lives. So why is the eligibility window so small? Last year, to address this policy, which is leaving countless people at risk, the board requested the Ministry of Health to expand free of charge coverage for the HPV vaccine. Again, I know that the province is paying attention to these public health trends, and I hope they are compelled to take action. The most upsetting news for me over the last months is that the consumption and treatment services at the Parkdale Queen West Communities Health Centre has been forced to close after the province pulled their funding. After the Community Care and Recovery Act forced the closure of several other sites across the city, Parkdale Queen West remained as one of the few places people who use drugs could use safely, while also having access to support like counseling and pathway to treatment. The first item on our agenda this morning is the annual update of the Our Health, Our City mental health and substance use strategy. As chair of the implementation panel for this strategy, I can tell you that much of our energy this year has been focused on responding to the closures of safe consumption sites. The first wave of closures has had detrimental impact on our communities, our streets, our parks, our shelter system, the remaining SCS sites, service providers, and people who use drugs. I know that the closure of the Parkdale Queen West site will only amplify the challenges we're experiencing on the ground. While responding to SCS closures was a major priority for the OHOC, Our Health, Our City implementation panel, our other two priorities for the year were reducing the harm associated with alcohol and mental health promotion. To create spaces for more focused discussion, we created working groups to tackle responding to SCS closures and alcohol-related harm, respectively. I'm very happy to welcome the chair of these two working groups here today, Colin Johnson and Jean-Francois Perpault, I know I pronounced that wrong, who are here to present alongside Dominic Popowich, Associate Director at Toronto Public Health. I would also like to thank all of the members of the Our Health, Our City implementation panel, as well as the members of the two working groups for their dedication throughout this challenging year. Your feedback and insight have been instrumental to our understanding of these issues and will continue to guide our responses. Finally, staff have prepared a report on their review of the Toronto Urban Health Fund. While this is still a lot of work that needs to be done to improve the program and make it more accessible to organizations seeking funding, I'm happy to support the interim approach. I'll also be moving a motion to ensure that the service that the AIDS Committee of Toronto is currently funded to provide through TUF are continued by another organization or organizations come to the end of March 2026 when ACT closes its doors. With Toronto signing on as a fast-track city committed to ending the AIDS epidemic, we must ensure that outreach is ongoing and AIDS prevention services remain available. On that note, I'd like to take a moment to recognize the World AIDS Day is coming up next week on December 1st. I'm proud to live in a city that takes AIDS seriously, and as an elected official, I'm committed to continuing to support the organizations who are doing the work. I know that was very long. I'd now like to hand it over to Dr. Murdy to share a few words. Thank you.
Thank you, Chair Moyes. Good morning. Welcome to the last Board of Health meeting for 2025. And I would also like to extend my warm welcome to Councillor Chernos Lynn for joining our Board of Health. Today we'll be presenting our update on Our Health, Our City, Toronto's strategy to improve mental health and well-being to reduce substance use-related harms across the city. The strategy's implementation panel and the three working groups, which include members with living or lived experience, have been meeting diligently over the past year to discuss advancing the three strategic priority areas. The first group has been focused on the closures of supervised consumption sites earlier in 2025. The second group is focused on alcohol, and the third group has focused on mental health and primary care. In addition to the presentation from Toronto Public Health today, I'd like to warmly welcome our guest presenters who are joining us here for today's update. Colin Johnson and Jean-Francois Perpault are both the co-chair for the Supervised Consumption Working Group and the Alcohol Working Group. And I'd like to thank them for their leadership in supporting Our Health, Our City implementation panel and this important work. I'd also like to acknowledge that we have an ever-evolving landscape of available services in Toronto, and that November 22nd marked the end of the supervised consumption site at Parkdale Queen West Community Health Centre with the termination of their provincial funding. The work of Our Health, Our City and the work of the Supervised Consumption Site Working Group is more important than ever as the City of Toronto navigates the ongoing changes to the available services that support the health and well-being of people who use substances. One of the goal areas of Our Health, Our City is also around the prevention of homelessness, as housing is both a fundamental right as well as a social determinant of health, given its significant contributions to keeping and staying healthy. Last week at City Council, Toronto Public Health contributed to the approved motion to oppose Bill 60 based on the proposed changes that would increase the precariousness of housing for people who rent in Toronto. Our second item today's meeting will provide an update on the most recent 10 years of mortality data surveillance from 2014 to 2013. This work includes analyzing causes of death, identifying emerging health issues, and examining differences in causes of death between males and females across the lifespan and across neighborhoods in the city. Monitoring mortality helps inform Toronto Public Health, our city partners, and our healthcare and academic partners on the types of public health interventions needed to reduce preventable deaths and address persistent health inequities in their city. As Councillor Moyes mentioned, since our last Board of Health meeting, Canada has passed a notable and unfortunate milestone in terms of losing measles elimination status due to the ongoing outbreak across the country. The loss of elimination status for Canada signals an urgent need for ongoing investment in our public health systems, institutions, agencies, and tools at all levels of government, and a significant look at how Canada can support measles elimination in other parts of the world where measles continues to circulate at high levels. We must address misinformation and reinforce public health as a trusted and credible source of health information. Toronto Public Health has repeatedly called for provincial or national vaccine registry to allow public health and healthcare providers to better track vaccinations in the population. Despite these challenges, I'm proud of the success of Toronto Public Health that we only had 10 cases of measles last year, despite over 2,000 cases of measles in the province. It's our hope that we can and will reestablish our measles elimination status. As we head into the holiday season with a number of social gatherings, I also encourage everyone who's eligible to get their COVID, flu, and RSV vaccines ahead of the respiratory illness season. I'm also encouraging everyone to take measures to protect themselves and those around them by considering wearing a mask in crowded indoor spaces, choosing well-ventilated spaces, staying home when you're sick, frequent washing of hands, and covering coughs and sneezes. For people who are at higher risk and are eligible, we also recommend speaking with your healthcare provider about respiratory illness care plan, including treatment options. And as Councillor Moyes mentioned, next Monday, December 1st, is World AIDS Day. This day, officially proclaimed in the City of Toronto, recognizes that we, as a global community, have the tools necessary to stop the transmission of HIV and end HIV/AIDS by 2030 by working together in our communities. I'd also like to acknowledge one of the community pillars, the AIDS Committee of Toronto, also known as ACT. ACT's work in the community has been instrumental in supporting individuals living with and affected by HIV and AIDS and reducing stigma. A few months ago, ACT announced that after 40 years of service to the city and its residents, they are winding down their services in early 2026. Toronto Public Health is committed to maintaining service continuity through other organizations and to sustain the work of ACT as we move towards a future with zero new HIV infections and zero AIDS-related deaths. Through the Toronto Urban Health Fund, we're discussing today as our third item, we'll be providing an update on their funding for urban health funded resources. It is this type of work that we do at the community level with partners across the city and across the health sector that positively impacts population health. And before I turn back to Chair Moyes, as this is our last board meeting, I wish everyone a healthy and happy holiday season and looking forward to you again in the new year. Thank you.
Thank you, Dr. Marie. So we have over 30 deputants on our list today, which is quite significant. And for that reason, I'm actually going to move a motion. Can I do? Oh. One moment. Councillor Bravo, are you here? A moment. Oh, here you are. Thank you. We need you for quorum. It's okay. You could stay just in the room. Thank you. So yeah, I'm going to move a motion to limit speaking time for 3 minutes and also closing the speakers list at 10 a.m. this morning. I'll move that. All those in favor? Opposed? Carried. Thank you. So we have 4 items on on the agenda for today. The first item is HL 29.1, Our Health, Our City, Annual Progress Report 2025. There is a staff presentation on this item, so I'll hold it down. Item HL 29.2, Updated Mortality Trends for Residents in Toronto. There's a staff presentation on this item, so I will hold it down as well. Item 29.3, Toronto Urban Health Fund, Grant Programs Review Findings and Next Steps. There are public speakers on this item, so I'll hold it down. And the last item, 29.4, Promoting and Delivering School-Based Vision Testing in Selected Toronto High Schools. This was from Councillor Pasternak, seconded by Councillor Cheng at Council. Councillor Cheng, did you want to speak to this item, or should I just move it?
I'm happy to just move it. It's fine. Thank you.
Okay, thank you. All those in favor? Opposed? Carried. Thank you. So we'll go back to the first item. HL 20.1, Our Health, Our City, Annual Progress Report. I'm going to ask Dr. Murray to introduce the speakers, the presenters.
Yes, thank you. For today's presentation from Toronto Public Health, we have Dominic Popowich, Associate Director, and we'll be followed by our guest presenters, Colin Johnson and Jean-François Coupeau.
Thank you, Dr. Murdy. Good morning, Mr. Chair and Board of Health Directors. I'm pleased to share the 2025 Annual Progress Report for Our Health, Our City, a mental health, substance use, and treatment strategy for Toronto. Next slide, please. Our Health, Our City lays out a compassionate, equitable, and evidence-based plan to improve mental health and well-being and to reduce substance use harms across the city. This 5-year strategy addresses the full continuum of care, from prevention to harm reduction to treatment. It recommends actions for the entire community, including government, healthcare leaders, schools, businesses, civil society, and all Torontonians. The strategy's development and implementation are guided by lived and living experience, equity, and anti-racism. Next slide, please. So the staff report before you today describes how Toronto's mental health and substance use landscape is shaped by intersecting challenges, including housing instability, cost of living pressures, and an unpredictable drug supply. This landscape is also affected by changing policy, including the Community Care and Recovery Act requirements affecting supervised consumption services. Other new legislation related to public consumption of illegal substances and landlord responsibilities with respect to drug use in residential units are also affecting this landscape. These interconnected issues require a coordinated and comprehensive response across all sectors. Next slide, please. So, Toronto continues to see high levels of drug toxicity. This is a key feature of the current landscape. The unregulated drug supply continues to cause many overdose deaths. Toronto's drug checking service has identified new and highly potent opioids in samples expected to contain fentanyl. Many samples contain multiple strong opioids and other depressants, such as veterinary tranquilizers and benzodiazepines, increasing overdose risk and complicating reversal efforts. In 2024, the most recent full year of data available, there were 4,076 non-fatal calls for suspected opioid overdoses attended by Toronto Paramedic Services. Please note that this only includes instances where 911 was called and therefore underestimates the true number of overdoses in the community. On this side, you will see that the Office of the Chief Coroner for Ontario has also recently reported over 450 confirmed deaths due to opioid toxicity in Toronto in 2024, 96% of which are deemed accidental. Toronto Public Health acknowledges that these deaths represent tragic and substantial losses of loved ones, friends, and colleagues. As in the rest of the province, an increase in opioid toxicity deaths was seen during the pandemic. The number of deaths has declined in 2024, as shown in this chart, and in the first half of 2025, but it remains 50% higher compared to the pre-pandemic average between 2017 and 2019. It is also important to note that this decline began prior to SCS closures in March of 2025. Finally, overdose is not the only measure of drug user health. People who use opioids face elevated risks of HIV, hepatitis C, wounds and other infections, hypoxia, traumatic brain injuries, and risk of harm or violence from using substances in unsafe or isolated settings. All of these harms are worth reducing. Next slide, please. So Toronto Public Health regularly reviews sources of information on substance use harms and mental health. Here's a sample of more recent data from Public Health Ontario, Toronto Public Health's Population Health Status Indicators, and other sources since the last Our Health Our City report. Data updates show that many key substance use trends related to alcohol, cannabis, vaping, and tobacco use are comparable to previous periods, and also to the rest of the province. Some mental health indicators have worsened, including the percentage of Toronto youth reporting fair or poor mental health, compared to pre-pandemic levels. A broader snapshot of these data is included in Attachment 1 to the report. Next slide, please. The Our Health, Our City implementation panel provides input and guidance on implementation efforts for the strategy. The panel met 5 times in 2025 and identified 3 current priorities. 1. Responding to supervised consumption services closures. 2. Reducing harms associated with alcohol. And 3. Mental health promotion and collaboration with primary care partners. To advance the first 2 priorities, the panel established dedicated work groups comprising panel members, subject matter experts, and individuals with lived and living experience. In a moment, I'll ask co-chairs from these work groups to share some reflections. For the 3rd priority, Toronto Public Health staff will build on existing relationships with health partners and use physician outreach mechanisms to share panel priorities. Once published, the panel will also plan to review the upcoming Thrive Toronto report card on mental wellness and psychological health to identify additional opportunities for action. While this annual report focuses on current priorities established by the OHOC implementation panel, important work continues across all of the strategy's strategic goals. This work is occurring across the city by multiple divisions and agencies, much of which is reflected in Attachment 2 to this report. Next slide, please. So, in January 2025, Toronto Public Health reported to the Board of Health on anticipated impacts of SCS closures. Since then, 5 supervised consumption sites and 3 urgent public health needs sites have closed, including the closure of Parkdale Queen West Community Health Center site over the weekend. Community agencies and people with lived and living experience with substance use are reporting signs of strain. Through the SCS closures work group and other channels, we've heard reports of an influx of clients from closed sites to the remaining open sites, more complex client needs, heightened community safety concerns and community tensions, and insufficient resources to meet the current demands for service. We've heard about burnout among staff at the remaining locations, reduced service availability, which contributes to isolation and increased health and safety risks for people who use drugs, and reports from residents citing increasing concerns about visible substance use, improperly discarded supplies, and safety in public spaces. These are serious concerns that affect people's well-being across the city. In response to the closures, the city is responding on multiple fronts. In part, city divisions and agencies have been monitoring a suite of indicators related to these closures. I'd like to highlight a couple of these now. Next slide, please. One indicator we've been tracking with support from the city's customer experience division is the number of services requested for needle or syringe pickup. As you'll see on this chart, in 2024 and in 2025, there appears to be a seasonal trend where these indicators rise in the summer months and decline through the fall and winter. While it is too early to determine the impact of SCS closures through this and other indicators monitored by the city, staff will continue to review new data monthly to see how these trends progress. For this reason, we are also exploring new sources of data, including from community partners, that could be consolidated to provide a more comprehensive picture of the current landscape. Next slide, please. We are also pleased to have access to some qualitative reports from the Social Development Division. The division's Violence Intervention and Support Unit supports 26 active safety networks across Toronto. 5 networks have provided feedback regarding impacts observed in their communities related to supervised consumption. Themes range from increases in public drug use, concerns regarding the availability of outreach, and supports including treatment pathways, as well as a rise in overdoses occurring near storefronts. This feedback is similar to reports from community agencies, as well as discourse in the media and social media. We acknowledge that some of these observations reflect an upsetting reality for some people. Next slide, please. I'll now move to highlight some work undertaken by the Alcohol Work Group. While the Alcohol Work Group is in the process of determining its focus areas, initial discussions have identified some key issues. These include a lack of awareness that good treatments exist for alcohol use disorder, insufficient harm reduction spaces and managed alcohol programs, unaffordability of medications, and a lack of options related to shelter or housing, such as sober living and women-only options. Some ideas for further discussion include opportunities to build awareness among medical providers and the public about effective treatments, increasing access to treatment services and medication, as well as education and training opportunities, including with specific populations. I'll note that this work will likely involve flagging issues for provincial and federal partners, given these governments' role in regulating alcohol and funding treatment for alcohol use disorder. Next slide, please. While I've provided a brief summary of the input we've received from the implementation panel and the work groups, I'm privileged today to be joined by two implementation panel members who have also volunteered as work group co-chairs. Colin Johnson, who's online, is co-chair of the Supervised Consumption Services Closures Work Group. Presently, he works as a consultant to governments, universities, and community organizations on issues ranging from bloodborne diseases, harm reduction, decriminalization of drugs, racism, colonization, and gender identities. He is the co-chair of the Toronto Harm Reduction Alliance and sits on the steering committee for the Canadian Coalition to Reform HIV Criminalization. JF Crépeau is co-chair of the Alcohol Work Group. JF is a senior policy advisor at the Centre for Addiction and Mental Health. He leads CAMH's public policy and advocacy efforts in the area of substance use, developing and communicating evidence-based public policy to governments and other stakeholders. I'll now turn to Colin for his perspectives.
Colin, can you hear us? We still can't hear you, Colin. Are you able to start? Go ahead.
Okay, thanks. So good morning, all. So it's been a real privilege to co-chair OHOC, so Our Health, Our City, OHOC's Alcohol Work Group with Suzanne Fish from Toronto Public Health. So I want to make just two main points to outline the real importance of our work in this area of alcohol. The first is the scale of the problem. So alcohol is responsible for more deaths, more hospitalizations, more healthcare costs, more criminal justice costs than any other psychoactive substances, opioids included, and it often gets forgotten. And as a policy advisor, I know this. I'm aware of the scale of alcohol-related harms in the city. But as part of this working group, which includes folks who are working on the front lines, it's been really eye-opening to hear of some of the real-world impacts on people at the front lines in Toronto's hospitals and community organizations. It's been frankly devastating. I don't mind telling you that the first meeting of the working group was fairly depressing, to be honest with you. The second piece is the really limited options that municipalities have at their disposal if they're looking to address alcohol-related harms. So the main ways from a public health perspective that you would want to address alcohol-related harms are to look at the price of it, the physical availability, and the promotion. And those are things that the province has been kind of going in a particular direction with those things, a direction that is kind of the opposite of what would be a public health approach. And the city doesn't really have control over those particular levers, which kind of points to the need for creative thinking. And that's exactly what this working group has been working at. Basically, this working group has been a table at which folks can come together, and I mentioned the first meeting was a little bit depressing. After kind of putting out laying out the problems that folks are seeing at the community level, we've been then putting our heads towards creative solutions. And as Dominic mentioned during the presentation, so the supervised consumption site closure working group is a bit further ahead in its process, but we've been discussing a range of potential actions that the city can take. So not only advocating to the province and the federal government for taking more of a public health approach to alcohol, but then actions that the city could potentially take, including some were mentioned during the presentation. So that would be some of the things we've talked about are increasing education among primary care folks about about alcohol use disorder and the existence of effective treatments for it. We've also talked about the potential for expanding stabilization centers. And all in all, I guess I just want to say that, first of all, I'm really pleased that our city is focusing on alcohol, just given the scale of the issue. And also the composition of the working group, I think, has been really thoughtfully, it's really thoughtfully composed of people from a real range of organizations and kind of places in the system. And I'm really looking forward to seeing kind of the solutions that we are able to come up with together. And yeah, that's about it.
Thank you so much. Colin, you back with us?
Yes, I am. Can you hear me now?
Yes, we can. Go ahead.
Okay, great. Okay, sorry about that. I don't know what happened. So I'll just proceed. When the overdose prevention sites originally closed, I gave a presentation then outlining what we thought would happen, and sadly, what we thought would happen has actually happened. Just a couple of items. One was the delay in setting up the overdose prevention site subgroup. That took a little longer than we thought would be needed. The other piece that we want to touch on is that we have enough data regarding what would happen with the overdose prevention sites. For example, the increase in crime, et cetera, all of which we have found to be not true. So one of the things we'd like the city to actually start doing is this handing out really decent, sensible messaging, attacking these misinformation and the bad messaging that we're getting from the press, as well as from some organizations that are somewhat impacted by some of this. Secondly, the other thing we'd like to touch on is that the Toronto Police Service, instead of actually charging people for public use, which they cannot address because the sites have been closed, which is where these people normally have been going to for those needs, it's pointless to give somebody a ticket, which from what I understand can reach up to $10,000. Nobody's homeless has $10,000 sitting in their pocket. We also know that their consumption sites slave lives. We know this as a fact. There's far enough data to do that. This is some of the things we need to start pushing, and the city needs to start actively messaging to the public, to make sure that everybody understands that the fault does not lie with the people using drugs. The fault lies with the fact that the overdose prevention sites have been closed. I remember there was someone mentioned about the changes in the number of syringes and paraphernalia being found. One of the things the safe consumption sites were actually doing was they were actually going out in public and picking up those used syringes. Now that they're closed, there's nobody to do that, and there's no funding for that. Which leads me to my next point. The city needs to start funding to the best of its ability harm reduction services. We can still save lives. This is the best that we can do. The city needs to actively start funding where it can harm reduction services across the board. The city also needs to challenge the community law act that the province has imparted, as well as Bill 6. Again, as much as they can. There are other organizations that are also part of this. And if the city can join with us in doing this, then we can send a clearer message to the province that this is not the way to go about, and it will not end well for people. People are dying, people will continue to die. And we had actually, with the work that we had been doing over the decades and over the years, we'd actually seen a decline in deaths from people who were overdosing. We'd actually seen a decline, in hospitalization, in paramedics being called out. We can get back to that, but it's going to take everybody working 150%. I think the final piece, because I'm looking at the time, I think the final piece that I'd like to touch on is that, this is not something that we don't have data on. We have data that already proves OPS sites save lives. We have all that data. The data that we need is to show the impact that the overdose prevention site closures have had on the city. That is where we need the data. And that data is available through the through public TPH and other services. So let's get that data. Let's work for going forward to next year. And let's do the best that we can to make sure that everybody understands what is actually happening. They see the impacts of what is happening, and the city can take steps to actually address that. And my last and final piece is we would like funding across the board, as I've said, but also that the city start funding satellite services where people can actually go to somebody's place, get the harm reduction supplies they need, since harm reduction supplies can no longer be handed out at the heart hubs. And I think that's all I have to say. Thank you very much. Yeah.
Okay, thank you, Colin Johnson, and thank you, Jean-Francois Gripeau. Because our presenters may have limited time here with us, I'm going to, before we get to deputants, I'm going to ask... Oh, you're still... Oh, I thought we were done. Sorry, continue.
Thank you very much, Mr. Chair, and thank you, Colin, and thank you, Jean-Francois, for your reflections and for your ongoing work and leadership on these groups. These are important issues, and we are grateful for your efforts, so thank you for being with us today. So moving on to the next slide, please. So we also want to talk about what the city is doing beyond indicator monitoring in response to these closures. So TPH is continuing to conduct surveillance of fatal and non-fatal opioid overdoses, as well as surveillance of substance use-related emergency department visits and suspected overdose cases in hospitals. And that's not necessarily specific to only opioid overdoses. We also continue to provide mobile outreach, harm reduction supplies, and overdose response training and treatment. In many other important ways, other city divisions and agencies support emergency and crisis response, community safety, needle disposal, shelter and housing services, outreach, food security, and other interventions that contribute to the well-being of all Torontonians. Finally, the work of multiple city divisions to monitor emerging data and information will continue to inform these responses. Next slide, please. So the report also provides an update on the Downtown Homelessness and Addiction Recovery Treatment Hub, or HART Hub for short. The Downtown HART Hub will provide clinical and support services to address mental health and substance use in the downtown core, along with referral pathways to supportive housing and other wraparound services. Staff are finalizing plans for the future location that will house several Downtown HART Hub programs and services, tentatively scheduled to open in 2027. Services will be offered across partner locations and through outreach efforts in the interim. While some services are already available or launching soon, Downtown Heart Hub partners are collaborating on a broader spectrum of services for clients. Partners offering services include Toronto Public Health, Unity Health Toronto, the city's Housing Secretariat, Toronto Shelter and Support Services and Social Development Divisions, Toronto Paramedic Services, Good Shepherd Ministries, and the Inner City Health Associates. Engagement is ongoing across multiple city divisions and health and community partners to develop an outreach and coordination approach for the Downtown Heart Hub programs and associated clinical services. We will align and contribute to citywide efforts, including the all-of-city response to homelessness. The city has also worked to develop proposed measures to support the initial program decision-making, support operational oversight, and reporting of program usage. These are reflected in attachment 3 to the report. Next slide, please. So in the next year, we expect work on the current priorities to continue. A refresh of the interdivisional table will promote continued alignment with emerging priorities across city divisions and agencies. And later in the year, recruitment will begin for the next implementation panel membership term, which starts in March of 2027. Next slide, please. In closing, I would like to extend my immense gratitude to the implementation panel and workgroup members, Toronto Public Health and city staff, and other partners for their hard work and collaboration in addressing mental health and substance use challenges in Toronto. Thank you very much.
Thank you, Dominic and team. So as I mentioned, I'll bring it in-house first to directors who want to ask questions of the panelists, and then we'll go to deputants after that. Director Dr. Zhao, go ahead.
So thank you both, Colin and JF, for the update. My question is to Dr. Kripo regarding the alcohol priority. I was just wondering, in terms of one of the topics discussed was treatment for people with alcohol use disorder. Is there anything being done currently to lower the cost of treatment, specifically acamprosate, naltrexone, for people interested in these anti-craving options?
Yeah, thanks for the question. That is one of the things that we've been talking about as a potential action item. I know that the medications you mentioned were recently, I think a couple of years ago, put on the ODB, the Trillium program. So they are technically accessible. I think what we've determined as a group is that what's lacking is public awareness and even healthcare provider awareness that those medications are A, effective, and B, quite available, and C, can be affordable also. We've talked about potentially, I'm not sure actually to what extent I should be talking about action items that we're still kind of that are in in development, but those are very much on our radar and things that we're working on, developing proposals around, if that makes sense. Yeah.
No, that makes sense. That's helpful to know, because often the public misconception is that rehab should be the first line, when in fact it's often the most expensive option, and those medications can be good alternatives as well. My other question is around cannabis and vaping, because those were also covered in the appendix as well. Was the reason to focus on alcohol because it had the highest emergency room visits, with a plan for focusing on vaping and cannabis in later years of the implementation group?
I believe that would be a question for...
To the chair, yes, that is the intent. We did have a strategic session with the implementation panel as to what would be the initial year priorities. So the 3 working groups were those initial 3, but certainly as we chip away at all of the priority areas of our health, our city, some of those future areas will hopefully be the next phases of implementation.
Great, thank you. Those are my questions.
Thank you. Any other questions? Councillor Cheng, go ahead.
Thank you, Chair. I have a question for Mr. Kripo as well about alcohol. I'm wondering, I think what you shared was very sobering, the stark reality of the harms of alcohol to our society. And I'm just wondering, in terms of public awareness, are there any thoughts about what kind of education campaign could be done to highlight the cost to healthcare, the impact on the justice system, as well as any connections to intimate partner violence? Because perhaps our provincial government does not have the full awareness of the financial, psychological, and overall well-being cost of society of alcohol.
Yeah, thank you for the question. Those are indeed things that that are high on our list of potential action items. Is some kind of education campaign specifically around the nature and the scope of alcohol-related harms. The items you mentioned are all very important ones, and it's hard to tell, to be honest, whether at the political level or public level people lack awareness or kind of know but just don't care so much, because alcohol is kind of celebrated and sort of glamorized, you know, in our society. But yes, though, that's something that's, as I've mentioned and as Dominic mentioned in his presentation, these action items of this working group are still very much a work in progress, but that's high on our list of potential items. Thanks.
Right. Yes, we have a warming center that was quite alarmed when alcohol was then made available at the nearby gas station, which previously was not, and created more risk for all the residents. So I think this public awareness is really important. The other question I have is related to housing and shelter options. Will the working group be preparing a report that could be shared with the Housing Secretariat and Toronto Shelter Services about things like sober living and women-only options and the lack that is currently being experienced by residents?
I'm not sure that's, Dominic, are you able to?
Yeah, thank you, Jeff. Through the chair to you, Councillor, the alcohol working group, as we noted, is still kind of, formulating its action items. Through that process, I expect there will be some discussion about how best to publicize and disseminate its advice and recommendations. As we noted, this work will continue into next year, and of course, we will be reporting in the future to the Board of Health in respect of, the findings and outputs of those final working group meetings, yeah.
And when is that report coming back?
We will be coming up to the end of term, so it would be anticipated in the beginning of the new term of the Board of Health.
Great, thank you. I have another question. I have a question for Mr. Johnson about the misinformation and information that is being shared about the safe consumption site closures. And I note that I think it's the National Post that has actually questioned that perhaps overdoses have not increased with the closures, and that perhaps there has been a benefit to the closure. So I wonder if you could speak to this misinformation and what type of data we're sharing that shows people what's happening.
Looks like Mr. Johnson's dropped off. Perhaps
Okay.
Dr. Murdy or Dominic can answer.
Sure, through the chair. Sorry, we lost Colin to speak to that more. I think we are certainly concerned about the narrative of trying to link anything specific to Toronto to the trends that we're seeing, when the trends that we're seeing are actually reflective of the trends we're seeing in overdoses at the provincial level, at the national level, at the international level. So we don't know all the full reasons as to why there's been a decline in 2024 and 2025, continuing to see, certainly in our paramedics data, in terms of the fatal and non-fatal overdoses that are being responded to by paramedics, but it's not unique to Toronto. So I think we do need to, we're obviously, and that's been one of the challenges we've had to directly say, can we assess the impact of the supervised consumption closures in and of itself when there seems to be a bigger trend happening both at a national and international level in terms of the drug supply and what's happening in terms of those overdoses. So I think we're taking a very cautious approach. We want to make sure that we're providing the right answer, that we're looking at not just association, but actually causality to say what is that difference.
Thank you. Those are my questions.
Okay, thank you. Councillor Bravo.
Thank you, Chair. I'm going to pick up on a question that Councillor Cheng asked, and just to probe a little further into what sources of data or what animate the insight that there's a lack of housing and shelter options, and identify specifically sober-only services.
Through the chair to you, Councillor. So this was input received from the experts and members of the alcohol work group. So they bring, perspectives ranging from across, treatment services to, lived experience and advocacy for people, who use alcohol and, the families of them. So that's been their preliminary input from that group. And certainly, we will, as we continue to work through the work group process, look to bring further evidence to bear on this issue.
And the presentation of options, offering options would be coming forward from the lens of this would help to improve health. Okay. The second question is more existential, picking up on the comment, I think an important insight, which is not only is alcohol now promoted and its harms really obscured, but there's, in a sense, that we have a provincial government that's presented its access as a form of, or expanded access as a public good. Can anyone comment on the relationship between alcohol, which is seen as largely benign in popular culture and in the society, and the relationship of alcohol use and other forms of drug use, which are criminalized and generally seen as a bigger problem to manage? If there is one.
To the chair, I think that is an existential question about how we perceive substances in our society. I think where we are with alcohol feels reminiscent to where we were with tobacco 40 years ago, where there is still a significant amount of industry pressure, as well as social acceptability to alcohol that there was with tobacco a number of years ago. We know how long it took with tobacco to be able to change cultural norms and to understand and to break through the evidence that actually it is a carcinogen, it causes cancer, it is very harmful to health in numerous ways. So I don't, I think we are looking ahead to say how much work we have to do with alcohol to continue to reframe the awareness that alcohol is a carcinogen, that alcohol does cause 7 forms of common types of cancer, that alcohol does have a number of other health as well as societal impacts that people may not be aware of to the extent of how much impact they have. So certainly I think we have a significant amount of work, and I think we're very pleased that this working group is looking at those issues.
Great. I think I was also asking about the relationship between alcohol use and other forms of drug use. So it's easy to say that there's people that consume alcohol and people that consume other drugs, and as if they were totally distinct populations. Just a quick comment on that, if you could.
Yeah, to the chair, I think substance use is compounded by different issues. I think certainly the Venn diagram of people who use alcohol versus people who use other substances and that intersection, we are certainly concerned about that intersection in terms of how people relate to it. But I think just in terms of the kind of the total populations that we're talking about in terms of reaching people who use alcohol versus other substances, I think that the issues that we're speaking about in terms of that rapid access and having treatment available, certainly concurrent disorders, treating multiple addictions at once can be more challenging. So I think, again, we're pleased to hear the recommendations from this working group looking at access to services to treat substance use more broadly.
Thanks.
Thank you. Seeing no other questions, I will ask a question here. So again, my colleagues touched on the alcohol in corner stores and being more accessible to people in general. But do we have any data as to how it's affecting or impacting young people?
So I think so that some of the changes that we're most concerned about are the massive increase in alcohol availability that you just alluded to. So this is still relatively new. So I think it was either in August or September of 2024 that suddenly, almost overnight, another 3,000 or so alcohol retail outlets came online in the form of convenience stores mainly. This has been, so just a little bit over a year, data collection is proceeding. I think that certainly anecdotally from clinicians who I work with at CAMH, it does sound like people, so there are potentially more people coming in with problems, but certainly people with existing alcohol problems, be it, like full-on alcohol use disorder or just like struggling with alcohol problems, maybe in a kind of like non-disordered sense, if that makes sense, are finding it very difficult to kind of manage these issues, considering just how like omnipresent alcohol now is. Not only alcohol being in convenience stores, but also, as I recently saw in a local Circle K, you go to the chips aisle and there's something like a little sign directing you to a beer, over in a different section of the convenience store that like pairs well with those particular chips. So it's a matter of availability, but also promotion and a kind of increased availability that has been done with very little kind of, I guess, kind of consideration of what that might be like for people with existing problems. So to circle back to your question, we don't yet have like hard data on the impact on young people, but anecdotally it does seem that some young people are finding this very difficult for people who do have like a problem with alcohol. And the international data tells us that we are very likely to see in a year or two's time, to see that like impacting in terms of, or expressed as an increase in, say, hospitalizations, for example, like among young people.
Thank you for that. To move on to the supervised consumption sites. So in the presentation, you mentioned that in the existing sites, there's increase, of course, of services to those existing sites, but also there's a potential for staff burnout as well. What are we doing as a city to support the existing sites?
Thank you, Mr. Chair. Yes, this is certainly a theme that has come through the work group discussions to date. So Toronto Public Health does, through its clinical services area, provide harm reduction services, and that includes, the distribution of harm reduction supplies. We also have, active outreach operations operating in the downtown area, and in addition to the downtown core program in the downtown central downtown area. In terms of other supports for, dealing with this kind of increase, the city is, looking at exploring other potential funding opportunities, including through the federal government's Emergency Treatment Fund. That application process is just closed, so we will wait to hear back whether we were successful. And certainly this is an area where we're going to continue exploring with the work group. One area I will note is that, we recognize that pulling together data to try and better capture some of the impacts of the closures is a labor-intensive process. And so right now we're engaged in discussions with the sites and work group members around how TPH can best facilitate those efforts and provide some additional support on that front. So that work is underway, and we will keep the board and the community apprised of those efforts.
Yeah, thank you. And when we talk about supervised consumption sites, we normally talk about staff supervising people using drugs, but there is clearly more that happens in those spaces. So can you probably maybe itemize or go through some of the things that actually happens at SCS sites, including community? Go ahead.
Yeah, to the chair, that is the idea of the sites, right? That they are sort of a first place to create that community connection for people who are using substances. So certainly there is the option for using substances within that site, but typically it's really about the relationship formation with clients who are coming to that site. So some clients may come to receive harm reduction supplies, just to needle exchange or pipe kits availability. Some people may come to actually have that supervised consumption. The counselors are there. Some people just sort of need a place to rest and relax for a piece, and have a safe space to be. And during that time, the counselors can also engage with them to see where they are in terms of their use. Are they willing or open to look at other treatments available? Are they willing to be connected to other social services? We have colleagues here from Toronto Shelters and Support, Social Development, the Housing Secretariat, to see are there other services that we can be connecting them to provide to help more of their holistic picture.
Including wound care and those sort of things too, right?
Certainly in the settings where we do have primary care availability, that may differ a little bit in terms of just how much primary care is available, but where there is, many sites do have that connection to primary care, and certainly the intention for many of them is to have that connection to primary care and those basic primary care services.
Okay, thank you. Any other questions from directors? Seeing none. So we'll move, thank you so much, presenters. And so we'll move on to deputants. First up is Ozma. Okay, 1 second. Councillor Peruzza, I know that you're online with us. Can you please turn your camera on for quorum purposes? While Councillor Peruzza is turning his camera, we'll ask that Ozma Ahmed is online from St. Michael's Hospital, Unity Health, Toronto. Okay, you have 3 minutes. Go ahead. You're on mute. There you go.
Hi there, good morning. Thank you for the opportunity to speak today. My name is Ozma Ahmed and I'm a research manager at the MAP Center for Urban Health Solutions at Unity Health Toronto. I'm also a registered clinical social worker and support different communities across my work, including people who use drugs. Today I'll be speaking to the Our Health, Our City report. Between November 2024 and January 2025, our team interviewed 29 clients and 10 staff from 7 supervised consumption sites across Ontario. We studied the short and long-term impacts of the government announcement to close consumption sites. I'm going to highlight some important findings. Many clients told us they didn't know the reasons for closing sites, the timing, or which sites would be affected. Some only found out about the closures during our interviews. Several didn't know whether access to harm reduction supplies would continue after the closures. The announcement had an intense emotional impact. Clients and staff experienced panic, stress, anxiety, fear, rage, grief, and a profound sense of powerlessness. Clients and staff questioned why sites were established and promoted as essential public health measures only to be taken away. Many asked why they opened at all, expressed deep distrust of public health, felt that justifications were disingenuous, and wondered whether decisions had been a setup. Clients emphasized feeling betrayed by decision makers who had first offered care and then abruptly withdrawn it. Trust with people who use drugs has clearly been broken, and there is a need to repair this through public health strategies. We also heard repeatedly from clients about how much they value child safety. Despite stigmatizing narratives that depict clients as careless, they described explicit rules and norms among people who use drugs to hide substances and supplies when children are present or walk by out of respect for them and their families. These findings suggest an important way forward for Toronto's drug strategy that includes people who use drugs when defining and implementing public safety concerns. Clients and staff caution that some people will be left behind through the heart hubs if they're not ready or unable to access the hubs. Clients also described feeling accustomed to judgment and being treated like garbage. They shared how the closures will either force them to use publicly or to hide their use and retreat, both survival tactics that compromise their own safety and strip people of autonomy. Harm reduction opponents often frame these actions as bad choices, but ignore structural constraints. I'd like to close with 4 recommendations for the city. 1, recognize the ongoing harms experienced by people who use drugs and the need to repair trust through inclusive and transparent decision-making. 2, include people who use drugs in defining and implementing public safety, recognizing their shared commitment to protecting children. 3, extend anti-stigma measures to position people who use drugs as leaders in designing, implementing, and evaluating initiatives that address dehumanization and misinformation. 4, ensure hard hub planning and evaluation center the preferences of people who use drugs. Thank you.
Thank you. Great timing. Any questions of the deputant? Seeing none. Ahmed Ayomi, online. Ahmed Bayomi.
Yeah, good morning.
Okay, go ahead, 3 minutes.
Good morning. My name is Ahmed Bayoumi. I'm a clinician scientist at St. Michael's Hospital, a professor at the University of Toronto, and a scientist at the MAP Centre for Urban Health Solutions. I published extensively on harm reduction services. My remarks today will focus on the closing of supervised consumption services in Toronto. Our research is available on the maphealth.ca website and report entitled Estimating the Effects of Closing Supervised Consumption Sites in Toronto. We are working to update these findings, including the closing of the Parkdale Queen West site. Our research focuses on estimating how many people will lose access to supervised consumption sites. We first estimated how many people who inject drugs are clients or were clients of supervised consumption sites in Toronto. Depending on assumptions how far people will travel, we estimated that between 31% and 83% of people who inject drugs in Toronto use a supervised consumption site, indicating that these services are used by a significant proportion of people who use drugs in Toronto. We also estimated the impact of site closure due to the passing of the Community Care and Recovery Act. We estimated on average over 1,300 unique individuals access supervised services each month in Toronto between April 2022 and March 2023. 41 to 57% of clients would no longer have services available at a site that they currently use. And of these, most would not be within 500 meters of one of the site that remains open. I emphasize that these are underestimates as they do not account for closing of the Parkdale Queen West site. As noted in the Our Health, Our City annual progress report, sites that remain open are already seeing an influx. It's also important to recognize that heart hubs will not offer supervised consumption services or needle and syringe distribution services. It's therefore unrealistic to expect to provide necessary services to all clients who will lose supervised consumption services. In closing, I have 3 recommendations. First, evidence on closing sites should be ongoing, timely, and comprehensive. Though I presented only quantitative data today, I underscore the importance of both quantitative and qualitative data for analysis. Second, the city should commit to making data as open and available as possible for independent analysis. Importantly, my lab and other investigators' labs had requests from some city data denied within the last year. Third, ongoing analyses, particularly of heart hubs, should focus not only on the services that they provide, but also include assessments of former supervised consumption site clients who are now not accessing other programs. Attention to these gaps in care is critical to understanding the full impact of site closures.
Thank you. Any questions for the deputant? Seeing none, thank you. Joseph Asenzo. Joseph Asenzo? No? Okay. Maswaskin Agnew, Toronto Indigenous Harm Reduction. Masquasin Agnew, online. Three minutes, go ahead.
Good morning. Can you hear me?
No, you're not the person I'm looking for. Ms. Waskin, Agnew, Toronto Indigenous Harm Reduction. We do see you online.
Good morning.
There we go. 3 minutes, go ahead.
Hi, my name is Ms. Gwasson Agnew. I work with Toronto Indigenous Harm Reduction. I also work at the Street Health Overdose Prevention Site. I'm a Cree and Dene woman from Salt River First Nation who was born and raised here in the city of Toronto. I'm here today to express my grief and to tell you about what my day-to-day experience has been as a community health worker. I've spoken to the board before about the disproportionate impacts to Indigenous community that the closures of safe consumption sites will have. I just want to share some of the stories and some of the things that I've experienced. So, one of the main things that happened that I noticed right away when the sites closed was actually a lack of access for people to get harm reduction supplies. And things that have, seemed so simple and seem so basic to harm reduction, such as bowl pipes. And because of needle exchange shuttering at certain locations, the works being the most significant of them, we can certainly expect HIV rates and other bloodborne diseases to increase as well. And of course, this is disproportionately impacts Indigenous community. We've also seen deaths since the closures. People I support have not been faring well since the closures of the sites. These are places that they depended on. And, it's not just the ODs, it's also the long-term complication that happens when you use drugs for an extended period of time, especially with the contaminants that are currently in the toxic drug supply we have now. And because of the shuttering of drug checking services, it's harder for people to understand what's in their drugs. And it's also harder for people to access safe supply. We're also seeing that because of people not being able to access their safe supply, they're returning to an illicit street supply of drugs. And I've actually responded to an overdose and one such scenario that was quite difficult to reverse and respond to. I would ask that the board keep challenging the province. I know that it supported the legal challenge to Bill 223, but the Parkdale site just closed, and it would be really impactful to hear a statement made by the Board of Health to educate the community, and so that public opinion isn't what makes decisions and determinants for our health and well-being, but evidence.
Thank you.
And thank you.
Thank you. Any questions for the Deputant? Seeing none. Thank you. Callum Houston, online. Callum? You got 3 minutes. Go ahead.
Right. Yeah, thank you, Board, for Health for having this meeting. The recommendations it was positive to see. Community engagement is exactly what we need. But I just urge that, and I think reiterating similar to what others have said before, that you're involving people who use drugs, frontline workers, people with lived experience in these evaluations, and not just relying on your normal partners that you have partnered with before. Not that they're not qualified, but it's important to cast as wide a net as possible. As I think the woman at Unity Health was saying, that many people didn't know that the safe consumption sites were closing and that did a lot of damage to their relationship with public health. And so if you're wanting to repair that relationship, you need to include them in that conversation. Even when there might be a small vocal minority of community members who want that site shut down or want those people to disappear. And those concerns are valid as well. There needs to be more sensible communication, public communication about what is going on and where the responsibility lies, because we all know it's the province that is doing this, that is causing this, and the federal government is not stepping in where they should. But the city is we need to see more messaging sensible messaging. So that's my main recommendation, or not recommendation, but my ask. And my other one would be similar to what Ms. Guanson said, to keep challenging the province, just like what the mayor did with Bill 60 and what the Board of Health has done with Bill 223. I urge you guys to continue to push, and we will continue to push as well. And that's, I'm going to secede the rest of my time. Thanks.
Thank you. Any questions for Deputy? Seeing none. Thank you. Justin Niera Ariza. Justin? No. Justin, are you in the room? So Justine, sorry, my apologies. There is an E at the end of your name. You're right, Justine. 3 minutes. There we go.
Thank you to the Board of Health for allowing me to speak today. My name is Justine Neidadisa. I'm a healthcare provider, community member, and a constituent of the city in Ward 9. On December 9th, people who use drugs, frontline workers, community members, healthcare providers, sat before you pleading to the Board of Health to step up as the province plans to defund SESs. Chair Councillor Moyes, you made amendments and promised Board of Health would look at all the alternatives to even maintain the works open. We continued showing up, we continued expressing our support, we were ready to meet. And here we are, almost a year later. Talking about tables, subgroups, work groups, while people are further marginalized, criminalized, left to worsening health conditions, and dying. Somewhere along the way, it was decided that agencies, health centers, and care providers simply had to do what they had to do with what they already had, with barely any increased additional support from any level of government and restrictions about what they could now offer. We are tired. 5 sites closed, 2 UHPN's sites closed, and where are people supposed to go? Heart hubs were supposed to be open in April 2025 as SES is closed, but they are still not operating. The Auditor General admitted that there wasn't a model behind this approach. Everything that's going on around us is an infringement in people's right to live. It is a violation of the Charter. None of these will be solutions to the problems that we're currently facing. People die while we continue to work on all of the things that need to be done, gathering data, etc. Recommendations from the medical officer health urges that Board of Health continues to recognize the drug toxicity epidemic as a public health crisis, but this is an emergency. So why are we not acting like it? I want to highlight the following as noted. The Board of Health requests the Province of Ontario and the Government of Canada to develop strategies for reducing harms associated to alcohol through evidence-based policies such as regulations on pricing, marketing, availability, and expanding treatment options. So we can talk about regulation, marketing, availability for alcohol, but we can't do the same for other drugs. Let's remember how we got here after a dangerous and deadly period through the prohibition time. In the pandemic, we started safer supply programs, then those got politicized and completely ripped away from people. I'd like to briefly share a quote from Crackdown, written by Garth Mullins. Politicians' solutions to drug problems are always laid on people who use them should do. You ask people that they should pull up their footstraps, detox, follow the steps, get sober. This isn't so easy. I would like to ask the Board of Health members if you've ever tried to get someone into detox, if you support them as they follow through the steps, to go see people go through withdrawal with no roof over their head or bathroom to deal with the bodily fluids that come. There are no treatment beds. You're lucky if you get to stay in a stabilization site for more than 3 days. We can't walk backwards. This isn't just about saving lives. This is about reducing complex health conditions that come. This is about communities that care for each other while the rest of society abandons us, and others make noise about their privilege getting compromised as they watch other people suffer. I ask today that you continue to challenge the province and the federal government. Thank you.
Any questions for Justine? Seeing none, thank you. Kevin Wilson. Kevin Wilson. Marina Klassen. Marina Klassen. Megan White. Oh, Megan White. Megan White. Juliana Collin. Online. Juliana Collin from Region Park Community Health Center. You're still on mute.
Can you hear me now?
Yes, 3 minutes. Go ahead.
Thank you. Thank you to the Board of Health for the space to speak today. And I also just want to say that I think it's pretty amazing that so many people signed up to speak today, and we should actually be making space instead of limiting community speaking times and sharing of experiences. My name is Juliana Coughlin. I'm a registered social worker at Region Park Community Health Center. I'm here to tell you a little bit about the work at Region Park, CHC, and the gaps that I believe that exist in the system. I think it's important to note that it feels like there continues to be a disconnect between well-written policies and reports and what's actually happening in communities across the city. As we have heard this morning, safe consumption sites are not just places where people use drugs safely. They are key points for low-barrier healthcare and social supports. For many, these sites are the only place where these supports are truly accessible without judgment or unnecessary barriers. I would like to know what the City of Toronto, and specifically this Board of Health, has done to publicly advocate with the provincial government against the closure of safe consumption sites. And with the closure of numerous safe consumption sites, including the recent closure of Parkdale Queen West, I am seeking clarity on how this board is planning to respond to the heightened pressures these provincial decisions will place on Toronto's harm reduction supports. How will the city ensure that people who use drugs can still access safe, evidence-based supports with such reduced capacity? I'm also asking the Board of Health to publicly advocate to provincial and federal governments to urgently reopen the Parkdale Safe Consumption Site at Queen and Dufferin, and then to reopen the other sites that have been closed. I also urge you to push back on misinformation suggesting that safe consumption sites themselves cause community safety concerns. The real issue is a system that deprives people of resources and pushes them into unsafe conditions. That is the violence. In the same document being discussed today, and we've heard this morning, it has been noted that Toronto Public Health works closely with other partners at the city level to provide shelter and housing. I asked the Board of Health how the different city departments, including Toronto Shelter and Support Services, are coordinating to address the crisis of affordable and safe housing in the City of Toronto. These are all intersecting needs, because right now in the City of Toronto, there are often no shelter beds. When you call and wait sometimes 30 to 40 minutes to get through to central intake, there's nothing. There are often no safe beds. And even when you call the crisis team that has been implemented, there are no beds often that come along. When someone wants a detox bed, it's very difficult to ever get a detox bed. And if folks get detox beds, they're often required to have medical clearance. And in the state of emergency departments in Ontario right now, that's often impossible. What myself and so many others do is often give Presto tickets for people to ride the 24-hour buses, Tim Hortons gift cards if we have them, for them to sit in Tim Hortons and then come back to the health center the next day for us to do again. And I'm not even talking about the year-long wait list for Access Point, Toronto Community Housing, Fred Victor, Wood Green Housing List. People have nowhere to go. I will end on this note. The system is not broken. The system was created this way through colonial government's actions to prioritize wealth over the lives of people who live in the city. I ask that the City of Toronto actually take action to support people who use drugs and people who do not have a safe home to live in. I ask that the City of Toronto, specifically this Board of Health, stand up to the provincial and federal governments and advocate for safe consumption sites.
Thank you.
You cannot, I'm almost done. You cannot force people into treatment. There are not enough detox or treatment beds that are even available at this time. People deserve better. Enough is enough. Demand more for our communities. Thank you.
Thank you. Any questions for the Deputy? Thank you.
Thank you.
Karen Rukas, online. Karen? Okay.
Can you hear me okay?
Yes, we can. 3
Can you
minutes
hear?
ago.
Okay, wonderful. Today, I'd like to address the homeless addict epidemic in my neighborhood, Toronto Centre, the Casey House, and Toronto's deeply troubling humanitarian record. Casey House was originally a specialty hospital providing inpatient palliative care for patients dying with AIDS. In 2021, Casey House shifted to offering outpatient services, focusing on harm reduction for homeless individuals, mostly substance users. Their outpatient program has now expanded to over 700 clients. Casey House offers substance users injection and inhalation drug consumption supervision and supplies inside the building. However, we see these same individuals shooting up along our streets and sidewalks, inside our parks, and outside our schools, as evidenced by discarded needles and other drug paraphernalia. While the staff at Casey House clean up their yard, the front yard, they do not move along Isabella Street to pick up the drug paraphernalia. As other supervised settings in Toronto have closed, the number of homeless addicts in our neighborhood, that's the Parliament to Bay corridor, has ballooned. Safe consumption sites were first introduced in Toronto in 2017 with the goal of preventing overdose deaths. So let's look at the numbers. In 2015, before it all happened, Toronto had 137 overdose deaths. In 2019, that rose to 300 overdose deaths. And by 2023, that rose to 525 overdose deaths. So I'm gathering that the program has not been entirely successful. Casey House consistently espouses the urgent need for more shelter spaces and rent geared to income housing. However, despite the visible need, and I'm talking about vulnerable homeless addicts on every single corner of our community, so much so that we're tripping over them, and who have exposed themselves when I've taken my 7-year-old granddaughter for an ice cream on Church Street. The city's response is hindered by insufficient funding for shelter construction, rehabilitation beds, and training programs that could help these individuals rebuild their lives. Many local residents express concern that Casey House's role in harm reduction services without prior neighborhood consultation has led to increased unsafe drug use and unpredictable and sometimes dangerous street behaviors, which we've all witnessed. Just 10 days ago, there was a stabbing at George Hislop Park, which forced the police to remove the encampment 3 days later, God willing. Our building has been vandalized several times, including nearby fire setting, necessitating us to call the fire department. The proximity of Casey House to residential streets, including a primary school, heightens these tensions. There is a clear desire for balanced, humane solutions that safeguard both the vulnerable populations and the broader community. In closing, while Casey House is a valuable hospice, its role as a safe consumption site must end, as this experiment that enabled addiction has clearly failed.
Thank you.
It is imperative for the city and provincial leaders to prioritize the homeless addiction problem that is plaguing Toronto. Thank you very much for your time.
Thank you. Any questions for Deputant? Seeing none, thank you. Margot Benson. Three minutes, go ahead.
Hi, good morning. My name is Margot Banson. I'm a public health nurse with Toronto Public Health. With 7 years seniority, I'm now the most experienced nurse in the Harm Reduction and Treatment Services program. We are servicing the community 365 days a year with no closures on weekends and holidays. Today, instead of working in the clinic, I'm here leaving my colleagues short-staffed to speak with you about the nursing shortage we are experiencing. Our nurses provide addiction, mental health, and medical outpatient treatment to vulnerable and often underhoused community members. We provide wound care, STI testing and treatment, vaccinations, community outreach, and case management to people who routinely fall through the cracks of our healthcare system. Referring clients elsewhere is extremely challenging when many do not have health cards, phones, or stable addresses. Many have been turned away from other services and carry trauma and stigma from past healthcare experiences. Our clinic is one of the few places they trust. We aim to provide comprehensive, continuous care so no one is left without healthcare. All this requires adequate, stable, and experienced nursing staff, which we do not have. We are currently short 7 out of 11 full-time nursing positions at my workplace. Recruitment and retention have always been a challenge. Nurses regularly pressured to work overtime, come in on days off, and cancel planned vacations or work other obligations. When no one volunteers, reverse seniority determines who must stay. This is unsustainable. Short staffing increases the risk of errors, burnout, and moral distress. Management cannot hire enough nurses to retain fast enough to keep up with the departures. Many leave for jobs that are better paid, less demanding, and more stable. A number of my colleagues work second jobs just to simply stay afloat financially. Public health nurses in our unit are at the top of the pay scale, are the lowest paid in Ontario and amongst the lowest paid in Canada. This pay inequity directly fuels our recruitment and retention crisis. We routinely lose strong nurses to neighboring healthcare units, hospitals, community agencies that offer significantly higher wages for equivalent and less complex work. Because we are so understaffed, we cannot operate at optimal level. For example, we once offered a nursing-led drop-in clinic providing essential medical and mental health care. These clinics were essential for building trust and creating opportunities for meaningful referrals. Today, we cannot staff this service. I want to praise the recommendations in today's report, but without proper staffing, meaningful recruitment, and retention strategies, pay equity for our nurses, mental health and addiction services will languish. Our clients rely on us, they trust us, they deserve stability, and nurses deserve wages that reflect the complexity and expertise of this work. Addressing wage equality is not simply a staffing issue, it's a client safety issue, a service quality issue, and is critical to public health. We need the board to acknowledge the severity of this crisis, to prioritize competitive compensation in upcoming decisions so our health unit can recruit and retain the nurses our community needs. We request the board make a motion to work alongside QP Local 79 and Toronto Public Health workers to report, on a report to be completed by city staff on what is needed to address these problems. That's why I'm here today alongside many public health nurses and inspectors to deliver a petition calling for a wage adjustment for health professionals signed by over 550 workers.
Okay, thank you.
Thank you.
Any questions for the deputant? Seeing none, thank you. Gabe Lawrence. Three minutes.
Thank you for having me. I'm Gabby Lawrence. I'm the Director of Harm Reduction Services at Parkdale Queen West Community Health Center. On October 23rd, 2025, the province announced it would terminate all funding for the Parkdale Supervised Consumption Service with 30 days notice. This decision signifies a devastating abdication of the province's duties to protect public health. To withdraw a proven life-saving service with only 30 days notice is not only short-sighted, but it's an inhumane act that will have fatal consequences. We are profoundly alarmed by this decision as it demonstrates reckless disregard for human life. The inevitable outcomes of this closure is the preventable loss of human life. This announcement follows last year's closure of 3 Toronto SCSs that were located within 200 meters of schools or daycares, including our site at 168 Bathurst Street. Since those closures, demands at the Parkdale site have grown by more than 60%, with 360 new clients relying on the service. This surge reflects the urgent need for accessible harm reduction supports as homelessness and drug toxicity continues to worsen. The PQW board and staff have made every effort to keep this life-saving service open, including requesting more time from the province. But with funding cut and the risk of operating without provincial and federal approval, we could not find a viable way forward. With grief and anger, we were forced to end supervised consumption services on November 22nd. We also believe that provincial influence led to Health Canada to revoke our federal exemption to operate. SCSs save lives. They prevent fatal overdoses, reduce the spread of infectious disease, connect people to housing and treatment, and reduce public drug use and discarded equipment. Closing them will not stop drug use. It will simply make it more dangerous, more visible, more costly for emergency services in neighborhoods. The ministry says the funding cut is part of the plan to invest in the new homelessness and addictions recovery treatment heart hubs. While we support expanded treatment options, these hubs cannot replace community-based harm reduction services. People need a full continuum of care. Closing SCS sites before alternatives exist is not a transition plan, it's a public health disaster. Some residents near the site have raised concerns about safety, including public drug use, discarded equipment, and visible homelessness. These issues are real, but they are not caused by the SCSs. They are happening across Toronto and across Ontario. What we need are emergency shelters, supportive housing with harm reduction, and community safety strategies built with input from both housed and unhoused residents. Our focus now is supporting clients in the community through these forced closures. Our transition plan include helping hundreds of clients connect with other services, expanding mobile overdose prevention supports, launching a mobile drop-in substance use care team to provide ongoing clinical care and overdose prevention in South Parkdale. We will look to the city and the Federal Emergency Treatment Fund to help fill the gap. The closure of this and other sites will put lives at risk. Ontario continues to lose about 200 people every month to the toxic drug crisis. The government's decision to defund and close SCS sites will only deepen this tragedy.
Thank you. Any questions for the deputy? Saying none. Thank you so much. NORAD Uzidi. Thank you. Yeah, 3 minutes. How do I pronounce your name?
Buzaid.
Buzaid. Okay.
That mic is live. Good morning.
Okay. Go
ahead. My name is Norad Buzaid. I'm a member of the Harm Reduction Advocacy Collective. I also am a harm reduction worker. I also have a lot of lived experience, both being unhoused and was formerly a substance user. This morning I've heard quite a bit the word crisis being thrown around, the toxic drug supply crisis. But it's very clear that people are not acting as though this is a crisis. I understand that provincially things have been laid out that we are supposed to follow, but we look at Bill 223, we look at Bill 6, we look at Bill 10, and the complete lack of democratic process that went into these bills, the lack of consultation from any outside organizations. And we've seen that again and again. We saw that with Bill 5, which is a complete disgrace to this nation's treaties. And we are seeing that with Bill 60 right now. And thankfully, the mayor has stepped in and voiced her concerns about Bill 60. And I'm wondering, where has that voice been for the people who are experiencing the toxic drug supply crisis? I would imagine it comes from the demographics. The war on drugs is rooted in racism at the end of the day. Black, Indigenous peoples, and people from lower class incomes are grossly overrepresented both in the unhoused community and among people who use drugs. And again, these bills that come out grossly over-affect them. To speak to the increase in overdose deaths and the increased visibility of homelessness in the city, to speak to that as a so-called failure of the SCSs, we all experienced the pandemic, and since the pandemic, the rate of homelessness in the city has basically tripled. So in terms of increased visibility, that's what happens when we don't have the proper resources to deal with these communities, with the drug-using community, with the unhoused community, which are not always the same community, but they do tend to overlap. Why are we fighting to keep our sites open when we should be building new sites? Again, the province laid out the criteria that needed to be met in order for an overdose prevention site or a supervised consumption site to operate. Why then did we not take that information and open new sites when we are seeing, as was previously mentioned, an increase in overdose deaths? The need is not going anywhere, and just because the Ford government is telling us that we cannot operate in a certain way doesn't mean that we don't then pivot and provide life-saving care to the most vulnerable people in our communities.
Thank you. Any questions to the deputy? None. Nicole Tollenauer. Nicole? Zoe Dodd. Line. Zoe Dodd.
Hi, thank you for having me here today. I want us to remind us all in this work, my name is Zoe Dodd, sorry, I'm a member of the Toronto Overdose Prevention Society. I've been coming to the city for over 20 years. I help with the expansion of naloxone, overdose prevention services, Hep C treatment programs, HIV outreach, helping to open warming centers and drop-ins for 24-hour drop-ins for women. And we've been here many times at City Council and at the Board of Health. And I want us to remind us all in this work that one death is one too many. Organizations from around the world have visited us and looked at us for our leadership in harm reduction and drug policy. The UN, the World Health Organization, public health units. We were leading in the world and we were showing real leadership. To answer the question of Councillor Cheng about overdose increases and decreases, we are beholden to the drug supply. On Saturday in Cowichan, BC, there were 80 overdoses in one day from the poison drug supply. Duncan is a town of 8,500 people. When an event like this occurs, like it did in the summer when we had carfentanil was in the drug supply, we relied on SCS. The Moss Park SCS actually reversed 60 overdoses in the month of August. Our city has zero mass casualty planning steps, and we have lost our main sources of understanding the drug supply in real time. SCS, who got drugs tested right away and fed this information to the public and to people using and to addiction and other healthcare providers who could adjust their prescribing and detox policies and overdose response protocols, we have lost this important source. Toronto Public Health and the Board of Health have wholly absconded their responsibilities to actually meet the emergency we have been in for a decade with the urgency and action that is required. This city is retreating after so many people fought extremely hard to save people's lives and develop evidence-based interventions. The city closed the busiest supervised consumption site and Neil Exchange program with nothing to replace it, leaving people without life-saving and disease-preventing services. These services cannot be replaced by more outreach cops, and a nod from City Council to open a non-evidence-based, abstinence-only hard hub model that even the Ministry of Health can't even support, really. 3 weeks ago, the Deputy Minister of Health confirmed that the decision to close supervised consumption sites was made for political reasons, not based on any evidence. The ministry was aware that closing CTS would increase the risk of drug poisoning, deaths, public drug use, and discarded drug use supplies. They decided to close the sites anyway for political reasons, and the hard hubs are not fully operational and offering the full scopes of services anywhere in the province. There are zero steps to actions in this report. Working groups are not emergency tables. Monitoring data with no action is violence. Data is being used as a weapon to do minimal to nothing, and we have been here before. I want to remind you that COVID-19 interventions were not politically palatable. During COVID-19, Toronto Public Health and the COMH had to make difficult decisions to protect the well-being of everyone. These decisions faced substantial backlash. Furthermore, you did not retreat, you innovated, you pivoted, you set up emergency tables, and you looked at the evidence. You did not make decisions based on complaints like people like Karen, who we heard before, complaining about addicts and homeless people on the ground, which are structural problems. We used research, we made decisions based on evidence. We do that. And so you spoke up about this evidence and spoke up against misinformation. And this is the energy we expect as we see this attack on and erosions of services for people living with or at risk of HIV, Hep C, people who use drugs and at risk of dying.
Thank you.
The failures of this board, city staff, and the COMH and the mayor, Olivia Chow, to stand up for people most marginalized has been shocking even today. People are not disposable, and there will always be people who hate others and want their existence to disappear. This country was built on this, and during important moments in history, this was used over and over. I have recommended.
Thank you very much. A question for the mover. Question for the deputant. Go ahead.
Hi, can you, I'm wondering if you're still there, the last deputant, and if you'd like to just finish their last points.
Thank you. Sorry, I'd written this for 5 minutes, so my recommendations, thank you, is one, to have the new medical officer of health releasing statements when the province and media misrepresents EMS mortality data and the toxic drug crisis. And this also includes crime data. We know that crime has not increased. The province should mount a legal challenge to Section 3 of the Community Care and Recovery Act. The section saying municipalities need provincial approval to ask for an SES exemption. Number 3, that TPH needs to focus on how to meet its obligations to provide sterile injection and harm reduction equipment and overdose prevention under the Ontario Public Health Standards. Number 4, work and advocate to the federal government to protect exemptions and reopen UPHS and shelters. Number 5, save the IO program. Number 6, protect the remaining OPS and SES. And in the words of ACT UP and AIDS Action Now, silence equals death.
Thank you. Okay. There were a few people that were not here earlier that I called their names out. Joseph Asenzo, are you here? Kevin Wilson, Marina Klassen, Megan White, and Nicole Tolliner. Okay, none of them are here, right? Okay. So we did ask questions of the presenters earlier, so anyone to speak on this item? Councillor Cheng, go ahead.
Sorry, Chair, I have other questions that I didn't ask because I thought we were just targeting the 2 people who had to leave. I have other, questions related to this. Can I ask a few more questions?
You did use your 5 minutes, Councillor Cheng, and we do have a full
I know,
agenda
but
today.
I'm just asking, these are very important data points, and I'm asking, I have 3 more questions.
Okay, I'll give you 3 minutes. Go ahead.
Okay, great. Thank you, Chair. I'm just wondering, there was some alarming data, and maybe it's not alarming because it's similar across Ontario, but 18% of youth at grade 7 to 12 reported that they have seriously contemplated suicide in the past year. And I'm wondering what data we have on the causes of this poor mental health and what is being done to address this, that 1 in 5 young people are considering suicide.
To the chair, yes, we're concerned about, as part of the overall our health or community, youth mental health is a strategic area that we do need to focus on. It hasn't been the priority for this year, but certainly through Toronto Public Health, working with our school partners, as well as other community partners in terms of looking at the youth mental health. We are looking forward to a Thrive report that is also looking at aspects of the youth mental health. In our most recent data on suicide ideation from pre-pandemic 2019 to 2023, that suicide was actually similar data in terms of for grades 7 to 12, in terms of the proportion of children who had seriously contemplated. So pre-pandemic to post-pandemic, similar numbers. But certainly we would look to certainly much of the disruption of COVID-19 as being contributing to poor youth mental health overall that we do need to continue to address.
And what percentage of those struggling with mental health and addiction have a history of childhood trauma or family violence? Do we have any information on that?
I don't know how that exact number off the top to the chair, but certainly a lot of the work that we're doing at Toronto Public Health is looking at adverse childhood experiences. So as globally, we know that this literature shows that the more adverse childhood experiences are experienced in early and youth childhood, then the more likely to have both physical as well as mental health conditions later on in adulthood. So certainly that correlation between youth experiences and trauma in youth to future substance use as well as other chronic health disease is an area that we are working on with our other city division partners to look at to address.
So therefore, when we are looking at upstream investments and ways that we can prevent addiction and mental health challenges, in fact, family violence and IPV, which is a source of adverse childhood events, could be an important way to prevent the crisis that we're seeing.
To the chair, I think we'd be looking to stabilize families overall. So certainly through Toronto Public Health, even starting from the very beginning, our Healthy Babies, Healthy Children, setting up positive parenting, supporting families at risk, and then working through schools and other tables through that childhood and youth periods to making sure that we are addressing all forms of trauma that might be happening in families, which may include intimate partner violence or gender-based violence within families, are ways that we are trying to work to prevent that overall risk of adverse childhood experiences.
Thank you. Those are my questions.
Thank you. Speakers on the item? I have it on my screen, so I will start. Oh, go ahead. Dr. Zhao, go ahead.
So I just wanted to speak on the harm reduction and the safe consumption sites. So in the journey to recovery from substance use, it is a continuum, and often harm reduction is part of the beginning of that journey. The purpose of harm reduction is to ensure that people who use substances can stay alive and healthy long enough for them to move to the next step in that journey to recovery, and the next step being treatment. It's very useful that we're collecting data right now on the overdose prevention, but I think we also should be collecting some data on how many people are being, or their lives that are being extended for them to move on to the next stage in terms of treatment and accessing treatment. So that was just something I wanted to mention and kind of give people the big picture as to where people are on the continuum, and it's not just the one or the other sort of thing.
Thank you, Dr. Zhao. I will speak on this item now. I do have a motion. You can put it on the screen, and I will read it out. That the Board of Health requests the Government of Canada to consider providing new mechanisms that allow the operation of supervised consumption sites, including new options for securing exemptions to the Controlled Drug and Substance Act. And 2, the Board of Health requests the province to reinstate funding for the Parkdale Queen West Community Health Centre Consumption and Treatment Services site, and increase funding for the other consumption and treatment services sites and other organizations who serve people who use drugs to address the increased demands for services. So I just want to state out loud again, and I have said this before and I'll say it again, that we as a city, as a Board of Health, have used every lever to, available to us to try to address these emergencies that we're in. When the province initially first addressed that they were going to be closing some of the SCS sites, one of the first things that we did was we brought together an emergency task force with all the heads of departments to put our heads together to figure out what we can do, including Toronto Services, paramedic services, fire, police, and other city divisions. It was also alluded to that we also joined the core challenge. One of the things, we haven't done this in the past, and that's one of the things that we actually did right away. We have also, on numerous occasions, as I have now, requested certain things from both the province and the federal government to address this crisis that we're in, and to plead with them to actually overturn some of the decisions they have made. And there's also a lot of work that is being done behind the scenes as well. It's not everything that is forward-facing. City staff do a lot of work to make sure that the province and other social services are aware of the things that we're doing, including, for example, providing support to, let's say, street health. I know that Gord Tanner and his team has sent staff to street health and other places to support the staff that are, overwhelmed and inundated. Again, that's not always things we discuss here, but that's one of the things that we have done and continue to do. And there's a lot more work to be done. And I remind people that healthcare is a provincial responsibility, right? One person, I think it was Justine, mentioned that we closed the works and they just walked away. Well, the building was sold and we were willing to actually move those services elsewhere. But the provinces said that we couldn't take our exemption with us when we moved. So it's not lack of trying. We would have liked to continue that service, but we were told, And again, maybe we don't do a good job talking about those things publicly. But I have to say to you that the staff here at Public Health are professionals. The people that they serve, are people that they know. Especially, for example, the works. They have a relationship with the people that they serve. One, to make sure that they are safe, as Dr. Zhao has mentioned. It's a continuum of care. So again, we will continue to do what we can in the capacity that we are able to as a board. But we share the same. We share what you share. We are concerned about the things that you're concerned about, and we are partners in this fight. So on that note, are there any other speakers on this item? Councillor Bravo.
Thank you, Chair. Through you, I just want to briefly thank all the deputants who came to bring their experience and knowledge from the front line of this. Yes, it is a crisis, and I want to just provide, in addition to some of the words that you spoke about in terms of our relationship with the provincial government, I think we are facing this situation with fewer tools than any other province in Canada for one reason. We're the only province where social services and social housing have been downloaded to municipalities. And while public health has always had a provincial dimension, a municipal and local dimension, the intersecting systems of healthcare, housing, and other systems like criminal justice system, child welfare, it would be really, it would be such a much better outcome for everyone, every resident in Ontario, if the provincial government looked at the challenges that we're facing with that perspective. The first piece being a place to live, a place to stay that's appropriate for people's needs as a foundational element, and looking at the entire system that can support and embrace a person and meet them where they are. That leadership is missing here, and along with the fiscal capacity. It's really about what we can do and what we can't do. It is entirely determined by the provincial government. So even when this level of government follows provincial direction, it can lurch from one day to the next. And I think it's a real problem in Canada where we don't have any constitutional powers at the local level, and yet we are forced to contend with the policy and funding decision outcomes that are experienced in real life by members of our community, and anyone who's in a situation where they are using drugs and finding themselves vulnerable and even homeless in the city are still our constituents, and we have an obligation to represent them despite this situation. So I wish I had more encouraging words to say, but I hope that everyone who is concerned and who has expressed their rage today can just, I'm providing this as a sort of context for the challenges of doing what we know works, which it would have been to keep these sites and to keep these services.
Yeah, thank you, Councillor Bravo. Any other speakers on the item? Yep, okay. Councillor Cheng, go ahead.
Thank you, Chair. This has been a difficult report to read, just knowing that there's so many crises happening at the same time, from youth mental health, the hidden impact of alcohol, to the safe consumption sites. And I think that, a lot of this needs more public awareness and visibility in order to garner the public support that it needs to move the dial on higher levels of government investing in the ways that they need to. I will say, though, that safe consumption sites are important, but it's part of a dialogue as well as to what kind of communities do we want to build and ones that garner trust. And we heard from one debutant in particular who lives near a place that is providing safe consumption and the impact on the neighborhood. And we know that the neighborhood impact at Leslieville that did lead to the death of a mom, that was the straw that broke the camel's back, I think, for the province to lead to their policy decisions. And so we can't just say, yes, let's keep opening more safe consumption sites without considering how we do it well. How do we do it in a way that doesn't cause children to be exposed to things that we don't want them to be exposed to? And in particular, I think about recently, there was a Globe and Mail editorial where the title was, "We have normalized delinquent disorderly behavior in our cities for too long." And I think across the country, people are reacting because they don't feel safe. They don't feel like they can go to the park without finding needles. They don't feel like they can go to the park without experiencing some intimidating interactions. And I don't think that that is right. I think we have to think about what are the gaps. And I do believe a lot of the gaps that we need to address do exist at the provincial level. How easy is it or difficult for someone to get treatment when they want to? If someone wants to stop using drugs, what is the distance between that decision and actually getting treatment? And so without those gaps being highlighted, without a more holistic approach, I'm afraid that we'll start to create a very polarized discussion where people who just want to experience their community in safety come up against advocates who are fighting for the lives of the people they love. And we shouldn't be pitting people against each other. We are all, wanting a safe society where everyone has the potential to live a life where they can fulfill their potential. And currently, if we don't have that proposal, what is that model of safe consumption that doesn't bring drug dealers into the neighborhood, that doesn't result in needles in the nearby playgrounds, that doesn't result in intimidating behavior in the community? What is a holistic approach that needs to be established? I think those are really important to garner trust so that it doesn't become as polarized as it has become. In my community, we are preparing to welcome a new shelter, and the main thing that people are afraid of is harm reduction. It's the question that keeps getting asked. And so fostering trust with society, with community, in how we approach this is key. And if the gaps are provincial, if the gaps are in the healthcare system, we need to point very clearly to where those gaps are. Yes, we need to make sure that lives are not lost. And I do believe it is terrible that the safe consumption sites close without the heart hubs being open right away. That I think is unacceptable, and we need to let the province know they really dropped the ball in this area. But we need a holistic approach to save lives, and that includes building bridges with the greater communities that are neighbors to those who are struggling with addiction. Thank you.
Thank you. Seeing no other speakers on the item, I'll ask that you put up my motion. All those in favor? Opposed? Carried. As amended. All those in favor? Opposed? And that's carried. Thank you, everybody. The next item is item HL 29.2, updated mortality trends for residents in Toronto. There is a presentation of this item.
Thank you, Chair. We have Dr. Nakashi Lamte who will be presenting this item today.
Thanks.
Good morning. I'm pleased today to present an overview of a recently posted report on mortality trends among Toronto residents on behalf of my colleague, Dr. Elizabeth Ray, and the Epidemiology and Data Analytics Unit here at TPH. This presentation will not cover the report in detail, but we will be speaking to the role of public health in surveillance, why these types of data are important, and some generally observed trends in the data. Next slide. A foundational role for Toronto Public Health and a core element of public health overall is to conduct surveillance and assessment on the health of Toronto's population. Population health assessment is primarily delivered by the Epidemiology and Data Analytics Unit at TPH, and population health assessment is mandated under the Ontario Public Health Standard. It involves measuring, monitoring, and reporting on health determinants, risks, and outcomes. Population health assessment informs immediate and longer-term public health interventions and health equity priorities. Population health assessment can be used to help plan, implement, and evaluate actions taken to improve the health of Toronto's residents. Not only are these data used by Toronto Public Health programs, they are also used by other city divisions, as well as public and private sector organizations. Next slide, please. Death, also known as mortality, is a foundational public health indicator. It reflects the ultimate health impact of a given cause, condition, or disease. One key measurement of this indicator is calculating the number of deaths in a population for a specific time, also referred to as a rate, which I will share in upcoming slides. Surveillance of mortality in the population is key to guiding public health action. For example, it informs priorities in reducing preventable deaths, which may be avoidable through public health intervention and primary prevention. Mortality surveillance can also help avoid premature deaths or deaths occurring before 75 years of age. Surveillance of mortality in the population can help identify new, emerging, and more immediate threats to the health of the public, as well as helping us to evaluate the impacts of long-term policies on mortality. Mortality surveillance complements the monitoring of other population health indicators. Toronto Public Health shares data on other population health indicators through dynamic dashboards, such as the Population Health Status Indicators dashboard, which was presented here at the Board of Health this year, the Toronto Overdose Information System, and the Integrated Respiratory Dashboard. Toronto Public Health recently shared a summary of mortality rates among Toronto residents, most recent 10-year period of available data, 2014 to 2023, and you can see here there's a live link to it. Next slide. Data for mortality rates in the population come from the Vital Statistics Registry. These mortality data include data from all death certificates submitted for Toronto residents. Death certificates contain limited sociodemographic details, such as age and sex. There is no race or ethnicity data recorded on death certificates. Other information captured on death certificates include the location of residence and the primary or underlying cause of death. Death certificate data are typically only available to Toronto Public Health after at least one calendar year. But the time between when an event or a mortality is reported and the availability to Toronto Public Health can last even longer than 1 year. There are other limited sources of mortality information. For example, death data can come from the Office of the Chief Coroner of Ontario, OCO, which investigates sudden or unexpected death. The Office of the Chief Coroner of Ontario data are available in a more timely fashion and in some instances include more detailed sociodemographic characteristics, vital statistic data. These numbers that we receive from the Office of the Chief Coroner of Ontario may not match the same or similar information vital statistics data. Other death data can also come from community-based reports, for example, shelters, which is also used to monitor deaths of people. Next slide. Next, we'll have a short overview of selected mortality trends observed in the report. This figure gives an overall picture of mortality rates over time, 2014 in Toronto. Overall, mortality rates decreased in Toronto in that time. There was a very slight general decline leading up to the COVID-19. While there are multiple factors that contribute to a mortality rate, this reflects the long-term impact of healthy public policies, such as those contributing to decreased smoking rates, leading to decreased lung cancer mortality. In 2020, you can see an increase in mortality with the onset of the COVID pandemic. We also know that there was an increase in opioid overdoses during this period. Mortality after 2020 decreased following the widespread rollout of public health efforts, including distribution of COVID-19 vaccines. In 2023, the mortality rate in Toronto reached pre-pandemic levels. As with other health indicators, there are differences in mortality. In 2023, mortality rates in Toronto differed by age. Older people had higher mortality rates than younger people. Mortality rates also differed by sex. Males had a higher mortality rate than mortality rates differed by geography. In the report, there are some neighborhood level differences that are noted. And finally, as shown in the figure, people living in the lowest income areas had 20% higher mortality rate than those living in the highest. Next slide. This table shows the leading causes of death by sex and age group in 2023. Colors are used to identify the same cause of death table. Premature deaths, in other words, deaths occurring in those aged less than 75 years old, are also highlighted. These may be priority areas for public health action, particularly if any leading causes of premature death are preventable or avoidable through public health action. For both males and females aged 20 to 44 years, accidental poisoning was the leading cause of death. As we just heard, our city highlights key action being taken by Toronto Public Health to address the drug toxicity epidemic. Ischemic heart disease, which is a cardiovascular condition caused by narrowing of the arteries to the heart, which may lead to a heart attack, was the leading cause of death for males aged 45 to 64 years and those aged 65 to 74. Public health strategic priorities, for example, those related to healthy eating, physical activity, not smoking, and promoting healthy aging across the lifespan, align with prevention efforts for this. For females aged 45 to 64 years, the leading cause of death was breast cancer. For those aged 65 to 74, the leading cause of death was ischemic heart disease. Dementia and Alzheimer's disease was the leading cause of death for both sexes for those aged 75 years. Next slide. While we have presented some limited data here, we encourage you to review the full technical report if you're interested. To conclude this presentation, we would like to highlight the importance of partnership in public health work. Public health information, like data on mortality trends, is being used by partners to inform decisions. Working with partners helps public health combine knowledge and resources to implement policies and programs to tackle the root causes of health. Partnership helps align priorities for maximum impact across the health sector. Next slide, please. This slide includes a statement from Dr. Stephen Wang, Director of the MAP Center for Urban Health, Canada's largest research focused on health equity and the health, and Anne-Marie Tynan, Manager of the Ontario Team Health Profiles Partnership. These statements underline the value of public health mortality surveillance for. Thank you.
Thank you, Dr. Lamke. We have 5 minutes before lunch, so there's time for 1 or 2 deputants. Squeeze every little last minute. Daniel Farheit, online. Daniel?
Can you hear me?
Yep, go ahead. 3 minutes, go ahead.
Yeah, thank you for the opportunity to speak, and welcome to the new member, Rachel Chernows-Lynn. I'm a frequent speaker here at this meeting. In fact, I think after the 10th presentation, I get my card stamped for a free smoothie. And I'm glad you cut it down to 3 minutes, because sometimes I get tired of hearing myself speak for 5 minutes. In terms of the mortality, this report, this updated mortality trend for residents of Ontario, fascinating. So my whole angle, okay, just to give a bit of background, is with what the city did in terms of the vaccine requirements for employees and general public health guidance and mandates for the public, and how that impacted public health. I think it ties into a lot of what we're seeing in terms of the mental health issues. I'm not sure what public health could have done to stop some of the provincial health issues or the provincial mandates. But in terms of what public health can do now, this business of surveillance, public health surveillance of mortality trends, you have to be mindful that there's a bit of bias in that. I think the board is not going to want to review policies that it implemented, especially during COVID, that may have compounded or may have negatively impacted mortality trends. I can't see my time, unfortunately, by the way. How am I doing on time?
Half a minute.
Left?
A minute and a half, sorry.
Okay, so I think what you have to do, so in terms of the mortality trends, I just posted on my Twitter, so I do advocacy on X under the Lion Advocacy handle. There were 442 deaths back in 2024 associated or linked to the COVID vaccine. Okay, this is the vaccine that was heavily promoted. Not all those were verifiably tied to the vaccine. 115 reports were missing information. 165 were unclassifiable due to lack of available medical information. So there's a lot of unknowns there. I can tell you anecdotally, I got a lot of calls from people who associated serious injury and with death, to death. So my point is, in that report, in the mortality trends for residents, it has a statement that that public health has, unquote, has assessed learnings from the pandemic response and incorporated them to prepare for future infectious diseases. I'm really concerned by that. I don't know what this board has done for this learnings business. I'll do an Access to Information Act request. Don't get me wrong. I'll find out what learnings you guys have done. You folks have done, but I haven't seen it. Like I'm trying to work with you guys to inform you. I'm not a crazy person. I'm trying to give you good information to help this learning, but I'm not seeing any action. So I'm asking for a motion by any one of the board members now to appoint an independent advisory group outside the board to make sure that these TPH surveillance and mortality surveillance is done in a non-biased way, totally independent. So anybody can make that motion. All you got to do is that little hand go up. So yeah, that's my bit.
Okay, thank you. You have 3 minutes. Next up is Melissa Law, and lunch is at 12:30, not 1 o'clock. 12, my mistake. Melissa Law, 3 minutes.
Hello, my name is Melissa Law, and I am a certified public health inspector in Canada with a bachelor's degree of applied science in occupational and public health. I have been working at the City of Toronto for the past 11 years as a public health inspector. There are about 100 public health inspectors who work at the City of Toronto. We are facing a recruitment and retention threat. Over the past 10 years, we have seen our colleagues leave the city for higher pay at neighbouring health units. I want to stay in Toronto because we have so much diversity. As a woman of colour, it is important to me there are people who look like me in my community, in my workplace, and in leadership. I'm deputing today to address how compensation for public health inspectors needs to be a priority in the 2026 budget. Public health inspectors are working every day to reduce mortalities in the community. We are environmental health professionals who work on the front lines as essential workers to protect the public from health hazards. We inspect restaurants, street festivals, childcare centres, group homes, swimming pools, beauty salons, tattoo and piercing shops, and more. We are involved in international events hosted in Toronto, such as the FIFA World Cup and the Pan American Games. We ensure public places are safe and sanitary to prevent illness and outbreaks in Toronto and those visiting Toronto. We are also investigators of infectious diseases and illnesses such as food poisoning, lead poisoning, legionellosis, and rabies. During the COVID-19 pandemic, we were ready to be dispatched into various frontline emergency response roles, given our professional background in science, investigations, infection prevention and control, case and contact tracing, inspections and enforcement. We were on the front lines enforcing the emergency orders by the medical officer of health. We were also there on the front lines for the 2002 SARS outbreak and the 2009 H1N1 pandemic. Our work contributes to reducing mortality rates and limiting the spread of contagious diseases. Like the public health nurses, many of our health inspectors have recently retired or are nearing retirement. Newly graduated health inspectors cannot afford to live and work in Toronto. Our pay issue is a threat to recruitment and retention of quality staff and experienced staff and jeopardizes our city's health as a result. We are requesting a modest and fair wage adjustment for public health inspectors in the 2026 budget to simply bring us closer in line with other public health units. York Region and Durham Region health inspectors are paid $5 to $10 an hour more than Toronto health inspectors. Public health inspectors are a key part of achieving the Toronto Public Health Strategic Plan priorities, which are strengthening health protection, disease prevention, and emergency preparedness. Our compensation must also be a priority. Thank you kindly.
Yeah, thank you. I did allow you to finish, but just as a reminder that it has to be topic-specific related. This item here is about the updated mortality trends for residents in Toronto. But we heard you loud and clear.
Thank you.
Thank you. Up next is Pia Berger. Is Pia here?
Yeah, sorry, I'm just unmuting myself and starting my video. Thank you.
Okay, 3 minutes. Go ahead.
Okay. Oh, sorry. Good morning. I'm grateful for the opportunity to speak today. I would like to raise some concerns regarding what I read in the report entitled Updated Mortality Trends for Residents of Toronto. I would like to start with the fact that there was no mention of excess mortality likely due to prior COVID infections. For example, studies have shown us that the risks of cardiac events occurring increases in both the short-term months and long-term years following a COVID infection. In fact, studies show that the long-term risk of heart attack, stroke, and death doubles when you have a history of COVID-19 infection. In addition, in the report, there was no mention of either long COVID or other secondary disorders associated with prior COVID infections. These disorders include, but are not limited to, cardiovascular disease, diabetes, and immune dysregulation. We know that all of these disorders contribute to increased morbidity, which in turn increases the mortality rate. It's unfortunate that this analysis was missing from the report. In my day-to-day life in the city, I see very little info from TPH, and I have concerns. I wonder to what extent people in the city have been made aware of the risks associated with COVID infection. I've spoken before to the board with a reminder that it's the job of public health to do preventative medicine. Preventative medicine includes education campaigns, not only on the risks, but also how to avoid those risks. And yet for diseases that are primarily spread through the air, we see reminders about hand washing and very limited emphasis on wearing N95 respirators. The public has a right to know about all the risks associated with COVID, including long COVID, and we have a right to know about the best methods, practices for protecting ourselves. Returning to the report, I would like to single out a specific statement on page 5, which is problematic in the way it was phrased. Quoting directly, the statement is as follows. COVID-19 still circulates in Toronto and can cause death at levels similar to other seasonal respiratory viruses. This statement is problematic for several reasons. First, we know that COVID is not a seasonal virus and that it circulates all year long. Indeed, we have in recent memory had summer waves. Second, COVID is not similar to seasonal viruses such as the flu in terms of its systemic impact, some of which I've already touched upon. We do know that unlike influenza, COVID is a neurovascular disease, which can get into the brain. Finally, again, I would like to point to this idea in this statement that suggests that COVID is only a problem in its acute phase. We should not be discounting, we need to measure it, all the knock-on effects of COVID in the long term, including but not limited to long COVID. Thank you very much.
Thank you. Any questions, Deputy? Seeing none. Thank you. Arnold Mark Willis. Arnold Mark Willis. Is he online? No. Okay. Louise Hittinger. Online. Louise? Okay, go ahead. 3 minutes.
One moment while I share my screen. Can you see my screen?
Yes, we can. 3 minutes. Go ahead.
Okay, thank you. I'm a member of Clean Indoor Air Toronto. I'm also a parent of children attending a TDSB school, and I'm a member of the Caring and Safe Committee of that school. Thank you, Pia, for that explanation about the effects of COVID-19 and climate change contributing to poor health and increased risk of mortality. In particular, COVID-19 is, we believe, contributing to excess mortality. The TPH pandemic response involved public education. I want to focus in on that aspect. COVID, measles, and many other serious infectious diseases are primarily transmitted through the air. And the next public health emergency is almost certainly going to be a disease also transmissible by air. At the same time, we're facing climate change. That means increasing incidence and severity of poor air quality and extreme heat days. We appreciate TPH's efforts, but most Toronto residents remain unaware of the multiple layers of protection needed for airborne disease and air pollution, and the information we're getting so far is not reaching its target audience. This is a really good example. Last week, I attended the Caring and Safe Committee meeting and asked that this TPH infographic, which was included in the TDSB Connects newsletter this month, be posted and shared in the school and included in the school newsletter. As it turns out, all of the other committee members had not seen this infographic, and that's not surprising because it's behind a hyperlink at the end of the newsletter, so it was missed. And the feedback received from the student and staff present was negative. They said this is going to be ignored. There's too much text, no one will bother to read it. Now, this infographic was shared on October 27th via social media, and it's simpler, easier to read, but unfortunately, we're afraid it's going to get misinterpreted. Most people are going to read this left to right, and it appears that cleaning hands takes precedence over ventilation and masking, and that's not the case for an airborne disease. This is the Public Health Ontario infographic, and it shows all of those layers of protection as a group, not in a hierarchy, and moreover, that Swiss cheese diagram at the bottom shows that the more layers of protection you use, the more risk reduction you get. This infographic was produced by TPH at the beginning of the year in response to a request by former TDSB trustee and now Councillor Nathan Chan. It shows a high-quality, well-fitted mask and the importance of air quality. Now, unfortunately, because clear directions were not given to the schools to share it, most of the school community hasn't seen it. So we're asking that TPH share the Public Health Ontario infographic in an updated version of the 4 steps for self-protection that includes Health Canada's new IAQ guidance that was published in September and give clear directions. Print and post hard copies. Embed images in newsletters, not behind a hyperlink. And we want less reliance on online resources that very few people are going to look for. It would be nice to have pop-up information booths, lunch and learn sessions. By taking actions now, we can reduce morbidity and mortality in the community and also improve our resilience to the next public health emergency and climate change.
Thank you.
Thank you.
Thank you. Any questions of Deputy? Seeing none. Thank you. And Heather Pun, are you here? Online, Heather Pun?
Hi, I just wanted to share.
Yeah, go ahead, 3 minutes. Go ahead.
It's saying I can't share. Oh, now I can. Thank you.
You can share now. Go
okay,
ahead.
great.
3 minutes.
Can you see that now? Can you see my screen now?
No, I can see your screen.
Sorry. Getting there.
Okay, I see your screen. Continue.
Great. Yep, I'm going. Just a second. Okay. So starting with the first thing, although it is no longer the threat it was during the initial phase of the pandemic, COVID-19 still circulates in Toronto and can cause death at similar levels to other seasonal respiratory viruses. This frames COVID as similar to influenza or the common cold. However, given that COVID is a systemic infection, it is not. The report of the data does not contemplate COVID's long-term impact on health as a contributor to mortality. Dr. Moriarty at U of T has tracked excess mortality that are likely due to prior COVID infections. In October last year, they estimated that the number of excess deaths from COVID yearly is more than the total number of deaths per year in Canada attributed to smoking, and more than 3 million people are living with long COVID severe enough to limit their activities. From JAMA Pediatrics, long COVID is common, affecting up to 10 to 20% of children with a history of COVID, potentially surpassing the number of children with asthma. To date, there hasn't been a single TPH communication to schools on long COVID risk. Why not? On Friday, CBC published this article, reported illnesses have tripled in some school districts. Experts say mental health is a factor. That looked at attendance from 2019 versus last year. Despite all districts seeing huge increases, there was not one mention of COVID or respiratory illnesses, completely ignoring the elephant in the room. If the Sick Kids Spit Test program is any indication, they now test for 5 illnesses, painting a concerning picture of the number of diseases spreading in our community, most of which are transmitted by air. Quoting the report again, informed by global, national, and provincial efforts to contain COVID activity, TPH responded to the pandemic using evidence and lessons learned from previous public health emergency responses. In a TPH staff SARS report from 2007, TPH was to apply the precautionary principle. From observations, this was not the case and continues not to be today. Public health precautions were lifted too quickly. Masks have been optional, and even the current respiratory virus season, Sick Kids remains mask optional. Telling people to consider masking is not good enough. Another quote from the report, TPH's pandemic response involves outbreak management, vaccination campaigns, public education, and surveillance to help reduce severe COVID disease outcomes, including death. What public education has there been on airborne transmission of disease and how to protect oneself? Hospitals have not moved to airborne precautions and continue to distribute medical masks despite confirmation that the method of transmission is airborne, giving people a false sense of security. Many patients are leaving with hospital-acquired COVID infections that spread to caregivers at home. I know of numerous. And the final quote, TPH has assessed learnings from the pandemic response and incorporated them to prepare for future infectious diseases and other public health emergencies. How is this being done and what are the details of this plan? The next public health emergency will almost certainly be due to a viral airborne infection. There has been little to no public education on precautions to take against airborne disease. If there was a new pandemic now, Toronto would be caught unprepared again. Why is TPH not showing information on precautions such as masking and improving indoor air quality?
Please wrap up.
One last slide, one finish. Public health agencies in other jurisdictions like New York City and Durham, North Carolina are providing this information to their communities. Is there a reason that TPH remains relatively silent on this issue? Thank you.
Thank you. Any questions for Deputy? Seeing none. Okay, thank you. We'll take it in-house. Any questions from the directors? Okay, seeing none. Speakers on the item? Speakers on the item? Okay, I'll just thank you to staff for this presentation, and this is very helpful. I'm going to ask Councillor Chernos-Lynn to move the recommendations on this item. If staff can put it on the screen.
I think it's just one recommendation, isn't it?
Yeah, it's just one recommendation.
Okay, I'm happy to move the one recommendation that's before us, Chair.
Thank you. All those in favor? Opposed? Carried. Thank you. And our next item, item 3, Toronto Urban Health Fund, Grant Program Review Fund findings and next steps. Is there a, okay, there's no presentation, but there are speakers on here. I was organized earlier. The first speaker on this item is Stashin Frederick, online. Stashin Frederick.
Yes, just 1 second. Sorry. I'm just having a bit of difficulty here. So thank you for allowing me to speak. So I am coming to speak in the role of President and CEO of Big Brothers Big Sisters of Toronto. But I've come to this conversation wearing several hats, each shaped by years of work in community health, youth development, and advancing equity across the city. My journey with the Toronto Urban Health Fund began long before my current role. As the founder of Braids for AIDS, I was a 3-time tough recipient using culturally relevant HIV/AIDS education through hair braiding to reach African, Caribbean, and Black communities. Later, as the executive director of Western Frontline Center in York Southwestern, we recently, before me leaving and becoming the president and CEO of Big Brothers Big Sisters, received funding from Toronto Urban Health Fund to address critical health inequities facing youth and families in Western. Those experiences have been very grateful to receive for addressing the health disparities, have given me a deep respect for Tufts' intention funding different, innovative, and equity-focused work. But they've also shown me repeatedly that barriers that many organizations like mine face in assessing and sustaining this funding. To be transparent, there were years where when neither Braids for AIDS nor Frontlines applied for TUF, not because the work wasn't aligned, but because the funding systems felt disorganized, burdensome, and at times very oppressive. The stipulations around finding different funding, the narrow funding streams, and the pressure around evaluation requirements, often without corresponding financial resources, became deterrents. These constraints were not just administrative, they shaped the possibility of applying. Organizations doing powerful, necessary health equity work opted out, not for lack of initiative, but because the system was difficult to navigate and unsupportive of the realities on ground. And today, even in the role as president of Big Brothers Big Sisters of Toronto, I find myself once again facing similar structural challenges. We're currently in a situation where late communication on required evidence tool and the work plan has put us to possibly making a decision about returning funds altogether. And TUF asking us to pause on programming until every youth participant is recruited, which is not reflective of how youth engagement realistically works, especially for vulnerable populations. We had requested certain funding and clarity up front, but this wasn't given to us.
Okay, thank you.
Let me be clear. Sorry?
Yeah, 3 minutes.
Okay. So I appreciate the shift towards a grants-based approach as a step in the right direction, But I must be honest, the current framework, which only accepts applications from organizations that were previously successful, leaves out a large group of organizations who no longer apply because of past systemic challenges.
Okay, thank
This
you.
is not
You're
reflective
at
of
time.
equity.
Thank
This
you.
is not reflective of.
Thank you. Any questions for the deputant? Seeing none. Janet Rowe, online. Janet? Go ahead, Janet, you're unmuted.
HIV/AIDS Support Action Network. We are currently funded by TUF for a 3-year grant, which ends June 30th. We're funded to provide HIV prevention education, specifically regarding sexual transmission, which I've always found very odd, as well as information about testing and linkage to care post-release. So I just want to say a few things. I'm happy to be deputing here. I think we were very surprised that this review was happened and that there wasn't a call for proposals. We were informed by our project officer. So I am here actually because I noticed in your recommendations that there's a recommendation about extending projects. And I think given the very short notice, as well as the very vague description about how that's going to happen, I want to compel the Board of Health to actually extend all projects that are in good standing. Particularly, and when we look at folks who are incarcerated, people who are incarcerated have very few options, and a gap in funding would increase the stigma and discrimination that people already experience. And when that happens, there's so much misinformation about HIV transmission. And coupled with the limited privacy around healthcare interactions, this contributes to further discrimination, social isolation, and involuntary disclosures of health statuses for people living with HIV. Within prisons, the systemic factors such as restricted availability of harm reduction tools, safer sex of condoms. I mean, people have access to it, but it's privacy is an issue. Punitive approaches to drug use and sexuality, and just operational barriers to confidential care. It just reinforces the stigma and increases the risk of poorer health outcomes. If there's a gap in funding, PASAN plays this vital role of providing in-reach support, education, and advocacy, and we're a trusted source of information. And I think that this was borne out during COVID, where we were available, and probably one of the only organizations that folks could access us for information about transmission. We provide that confidential information over the phone and in person, one-on-one. We do know that HIV is more prevalent for prisoners. We also know that prisoners are not really represented at EpiData. Very often, folks are actually lumped in to a group or assumed to actually be caught in another group without addressing the very unique stigma and discrimination issues that folks have inside, as well as access to very little, and particularly in provincial institutions. I think that the gap in funding will actually lead to, we already know that folks, if they're living with HIV, have a lot of treatment interruptions while they're
Final thoughts, please.
Pardon me?
Final thoughts.
Final thoughts. Okay. So I really recommend extending all projects, engage equity to serving communities in all priority setting application and reporting processes, consider the unique needs of prisoners, and know that prison health is public health.
Thank you. Thank you. Any questions for the deputant? Seeing none. Thank you. Arpa Azimila. Arpa Azimila. Did I pronounce your name correctly?
Arpa Azimila.
Okay. 3 minutes. Go ahead.
Thank you. Good afternoon. My name is Arpa Azimila. I'm a harm reduction manager at Parkdale Queen West Community Health Center. I'm here alongside of members of TRIP and Satellite Program staff who will be speaking later on to appeal for the continuation of the funding for these essential life-saving services. The lack of timely communication about not opening the Toronto Urban Health Fund this fall leaves us and vulnerable communities we serve at dire risk. The proposed interim approach to pause the general grant cycle and extend the 2024-2025 project without clarity on criteria of extension and adaptation is creating an immediate crisis. If this critical funding stream is cut for us, it will eliminate two of the most effective peer-led harm reduction service models in Toronto right when our city needs it the most, with continued attack on harm reduction services, bills and policies built to further isolate, stigmatize, and devalue the lives of people who use drugs. We are asking for immediate and automatic extension and continuity of both TRIP and satellite project for the 2026 and 2027 cycle, and advocating for prioritization of harm reduction services. The urgency of this request cannot be overstated. On November 22nd, 2025, our organization, Parkdale Queen West Community Health Center, saw its last remaining supervised consumption site close, making it the 5th closure in Toronto. After the closure of the 4 sites in Toronto on March 31st, 2025, including our Queen West site, our Parkdale site saw over 60% increase in visit and 300 new clients in very few short months. The closure of the 5 SCS sites, including the recent Parkdale site, has immediate and catastrophic consequences for both programs, as it would drive more people to use substances alone in their dwellings, force them to share drug use equipment, and limit their connection to information, education, and other health and social services. Thus, the further increasing number of preventable overdose-related deaths and rates of HIV and Hep C. These services were critical yesterday, and they're absolutely non-negotiable for our community's survival tomorrow. The satellite program targets the deadliest front of overdose crisis, private residences, which accounts for 56% of overall opiate toxicity deaths. The program based out of Parkdale works because it's low barrier and peer-led model. Between July 2023 and June 2025, the program has documented 7,210 client interaction. 47 of these clients do not access harm reduction supports and services anywhere else. The satellite program has provided 3,319 warm referrals, surpassing our referral goal for this project by 268%. These are communities who don't trust institutions like us and are connected to vital supports through the trusted relationships built by their peers to the services. With the SCS closure, its role as a residential safety net is now paramount. The TRIP project, with 15 years of track record with TUF, is a youth-led harm reduction health information service that is setting the standard for equitable outreach and is widely recognized for its truly youth-led empowering approach. TRIP is now more essential than ever. Over the last few years, we have seen diminishing youth harm reduction services, and with the closure of SCS sites, TRIP is now more important than ever. Youth seek peer-led programs and support, and TRIP provides that for them.
Final thoughts, please.
So we are asking for automatic grant renewal, more clarity and prioritization of harm reduction services for the consideration for the expanded and adapted services. And we're also asking for any review to include the communities who are impacted the most, the people who use drugs and our organizations who are impacted by the TUF funding. Thank you.
Thank you. Any questions for the Deputy? Seeing none. Thank you. Sani Hasimi. Okay, 3 minutes, please.
Hi, thank you. My name is Sunny Hashmi. I'm the coordinator for CHIP Project, a youth-led harm reduction initiative currently operating out of Parkdale Queen West Community Health Center. We've been funded by TUF for 15 years. However, CHIP was founded 30 years ago in 1995 as a grassroots sex and drug use youth education project. We are one of the only youth-led harm reduction initiatives in Toronto, which means any disruption in funding leaves a critical gap in support for high-risk youth between 16 and 29. That's why I'm here. I'm asking you to endorse the interim extension of TRIP Project's funding for the 2026 to 2027 funding cycle. TRIP Project is a volunteer-based organization. Twice a year, youth from all over Toronto sign up for volunteer training that covers overdose prevention, CPR, substance use health, sexual health, consent, accountability, HIV and Hep C prevention, and more. They join our team and help us reach and support thousands of other youth citywide. We also employ 4 youth peer workers who take charge of outreach and lead our harm reduction trainings and workshops, not just for our volunteers, but for service providers and youth spaces across all Toronto. There's huge demand for our program. Every participant in our spring 2025 training reported a dramatic increase in knowledge of harm reduction strategies. All of them left feeling more capable of responding to overdoses and committed to using what they learned to protect themselves and others. By the summer, the majority had already put these strategies into practice. Nearly 70% of the trainees learned where and how to access critical health services they didn't know about before. But our work doesn't stop at volunteer training. On outreach, 1 in 3 youth we spoke to had attended a TRIP harm reduction or overdose response event within the past 6 months, and most have reported that they were actively using what they had learned to reduce harm from substance use. And as coordinator, I have a unique history with TRIP as well. I started volunteering with TRIP when I was 17 years old, using substances regularly with inconsistent housing. At the time, I just wanted something to do, and much of my community was already involved with TRIP in some way. However, after a while, TRIP ended up being an indispensable resource and even a home for me when I did not have one. TRIP gave me somewhere to go when I didn't have it, a way to contribute to my community when it felt like I had nothing to offer, and it built confidence that my voice was worth listening to. When I was 19, TRIP even set me up with a scholarship to speak at the Drug Policy Reform Conference in Los Angeles on youth drug trends and issues. I spoke at a roundtable with lawyers, state representatives, and harm reduction advocates I had only read about, but please don't look up the video. It was my first public speaking experience. It's so bad. Anyway, I was a volunteer, and then I was a peer worker, and now I am the coordinator. And all I hope is that I can give other youth the same life-saving supports that I received. For 3 decades, TRIP has helped Toronto youth navigate the complexities of substance use, sex, relationships, and survival in a uniquely relevant way. As harm reduction services continue to be defunded and closed, TRIP project remains more crucial than ever. So please, I hope I've encouraged you to support the automatic extension of TRIP project's funding for the 2026 year.
Thank you. Thank you very much. Any questions for Deputy? Seeing none. Thank you.
Thanks.
Kathleen. Okay. Councillor Fletcher. Councillor Bravo. We have a motion to extend. All those in favor? Thank you. All those in favor? Opposed? Carried. Kathleen Pinero. Are you here? 3 minutes.
Hello, chairpersons, members of the board, and my fellow colleagues. My name is Kathy Pinero. I'm here today as a representative of Parkdale Queen West Community Health Center's satellite program. I am a harm reduction peer worker whose home base is located in South Parkdale near Dufferin on Queen Street. For the past 7 years, the Toronto Urban Health Fund, TUF, has funded the satellite program, which has proven itself to be an invaluable and essential service. As members of one of Toronto's most marginalized communities, we are requesting that services not get interrupted, and that the satellite program be considered for automatic extension and renewal of funding for 2025 through 2027. According to Toronto Public Health reports, low income is directly tied to chronic health conditions and inequities. The satellite program is in South Parkdale, where the median income is $24,000 below the Toronto average. Our clientele is made up of people who have drug ailments and addictions, who often face judgments and stigma. Some clients will even isolate and not go out into the public at all because of their perceived belief of persecution. Our peers have lived experience and understand these feelings. We are from the same community, and our faces are familiar to the neighborhoods. We are approachable and deemed safe. Trusting and lasting friendships are often formed. Satellite peers will address structural barriers and offer support and provide referrals. If the client requires the support of another person to attend a meeting or an appointment or go out on an outing of some sort, the satellite program can help. Although not a common request, it's another service the satellite program will accommodate. The satellite program is the only service that reaches people inside their homes. Initial contact is usually for the purpose of accessing harm reduction safe supplies, which starts the relationship. But once we have a relationship, peers now have an opportunity to assess the client's needs and determine if further assistance and or services are required. The satellite program ensures that clients' voices are heard. The program ensures that all members of the community receive the same services and attempt to obtain a better and healthier life. Toronto Public Health data shows that harm reduction supply distribution is safe and effective in reducing the spread of blood-borne illnesses like HIV and hepatitis C. It also helps people avoid adverse health outcomes such as infections, abscesses, and other medical complications. The satellite program reduces the satellite program's primary objective. It's for at high risk and high risk clients to help practice safer ways of using drugs. It's a lifeline for a lifetime. On November 22nd, the government ordered the closure of the consumption site here at Parkdale, which means our services are going to be more needed than ever. The city's own data from October of this year confirms that the majority of opioid toxicity deaths occur in residential settings. With our supervised consumption site being closed, we expect the usage will definitely spill out over into the residential areas. After all, where are these people going to go? We can close the doors, but we can't stop people from doing drugs. The satellite program is unique in that it employs fellow peers to distribute and lock and deliver overdose response trainings, thereby giving increased knowledge, skills, and confidence to clientele and members of the community. Harm reduction, distribution, and surprise consumption programs typically reach higher rates for men and women. Evaluation of satellite programs show that they tend to reach people who use drugs bring systematic gaps. Cutting a 7-year program that is successful closing city. Cutting a 7-year program that is successfully closing health equity gaps, health equity gaps, diverting used needles, and acting as the only lifeline for many clients, especially in the face of the recent SCS closure, is not an option. We are an essential service, and we are more important than ever. So I urge you to please endorse the automatic extension of the satellite program for the next tough funding cycle. Thank you for your time and consideration.
Thank you so much. Any questions for the deputy? Seeing none. Thank you. Questions of the board? Seeing. Oh, there's one more speaker? Oh, you're right. Marlon Lim, L-Y-M. Marlon. Is Marlon here? Not online and not in the room? Okay. Questions from members? Seeing none. Speakers, the item? Okay, I do have a motion. Staff will put it on screen, and it reads, the Board of Health recommend that the Medical Office of Health identify another organization or organizations to address any gaps in services and support most impacted by the closing of AIDS Committee of Toronto, which is better known as ACT, for gay, bisexual, queer, and other men who have sex with men, including those who use substances by February 28, 2026. Yeah, and as we know, that ACT is closing, and the service they provided, especially during the AIDS crisis in the early 90s, have been essential. And there's still, the need is still there, of course, and the services they provide still very important, including counseling and harm reduction and others, and also supporting those who are still living with AIDS. So it's important that before they close in March of next year, or that we make sure that there's a home for the services that they provide now. And so, yeah, that's the gist of my motion here, in addition, of course, to the 2 recommendations that the board itself has brought forth. Okay. Seeing no other speakers on the item, I will ask staff to bring the motion forth. Put it on screen. All those in favor? Opposed? Carried. As amended. All those in favor? Opposed? Carried. And that brings us to the end of our agenda. So thank you to all those who came in today. Thank you to those in the room and online. And of course, a big thank you to our staff, and specifically our clerk staff. Thank you.
Thank you, everyone.
Keisha. I want to get my stuff first.